Good morning. We are 10 o'clock and it is Monday the 20th of September. I'm told the live broadcast is going out, so welcome this morning to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind you this morning that the meeting is recorded, and for those of you who want to watch it back, the recording can be found on the County Council's website. The meeting is also being beamed live for people involved, and there is a cut-off of about 20 seconds after we've turned off the machinery, so I do encourage members just to give a bit of time for that. All the voting committee are in the chamber this morning in person, and there are a variety of people, principally our guests, who are virtually online. So first of all, welcome to you, committee, and also welcome to our guests. When we come to it, I would encourage our presenters to restrict their opening comments to 10 minutes, please. And then we can get into the scrutinising of the issues on the agenda. And please, can I ask that we focus on tangible outcomes for the residents of Staffordshire and not get too het up in process terms. So, on to the main agenda this morning. First of all, can I have apologies? Please, Debs.
Thank you, Chair. Apologies from Councillors Martin Buttery, Colin Wileman, Ian Wilkes and Councillor Sam Thompson, who would have been substituting for Martin Buttery. Councillor Phil Hewitt is joining the meeting shortly.
Can I just confirm that we are quorate? We've got a whole stack of very good people in front of us, so I see no reason why we're not quorate.
Yes, Chair, it's 6 to be quorate, and we are quorate.
Always good to have that confirmation. Thank you. Second of all, declarations of interest.
Yes, Chairman, can I declare I am the Partner Governor and the Midland Partnership Foundation Trust. I declare this at this meeting because I sometimes feel that, it might be brought into the meeting, the Midland Partnership. So, but whether I do have to declare an interest, I'm not right sure, to be honest with you.
In terms of today's agenda, probably not, but always good to be better safe than sorry. Any other declarations of interest? I'll take that as a no, thank you. So moving on to item number 3, minutes of the last meeting. So there are 2 sets of minutes to go through. The first set of minutes relate to the 26th of July 2020, which is the Wally's Quarry meeting that was held in Newcastle. So can I ask if the minutes are a true record of our meeting on the 26th? For those of you who were there, firstly, are they an accurate record? Seconded. Thank you, Anne, and thank you, Keith. Are we all in agreement with that? Getting enough nods around the room. Thank you. Appreciate that. So they are approved. And in terms of matters arising, I understand that the matters arising from the meeting are actually have been circulated prior to this meeting. I don't intend to go through them. There's nothing further that I wanted to add in that respect. Charlotte, did you indicate? Oh, you were just scratching your head. That's fine. Apologies for that. So moving on to the minutes of the 9th of August. Can I have, are they an accurate and true record? Keith, Flunder, seconder.
No, I wasn't at the meeting. I just wanted to give my apologies for that meeting. Unfortunately, I had a last-minute booking to move away for the weekend and completely forgot to send my apologies. So apologies for not giving my apologies at the last meeting.
That's noted. Obviously, you can't propose the minutes given you weren't there. Absolutely. Can I have, thank you, Richard, and can we have a seconder for the minutes? Thank you, Janice. So are we all in agreement with that? I've got a few nods around the room, so I'll take that as that we are. And in terms of matters arising, Debs, can you just confirm there's nothing that's not been circulated?
Yes, Chair, we are awaiting something from the maternity services, but that will be circulated when received.
Thank you. I appreciate that. So before we move on to the next item agenda, there has been a request to move item 5 forward, because Dr. Clarkson has an urgent meeting that they need to attend, and so I'm going to suggest that we bring forward item 5 and then move to item 4. Are we in agreement with that? That's fine. So on that basis, let's go on to item 5, which is transforming urgent and emergency care. I believe, is it Marcus, you leading us away with this? 10 minutes? Brilliant. Marcus.
Yes, I'm indeed, Chair.
Just
Thank you.
as we go, can we just introduce ourselves for those people online when we come to speak for the first time, please?
Yeah, will do, Chair. So I'm Marcus Warnes. I'm the Accountable Officer for the 6 Staffordshire and Stoke-on-Trent Ccgs. I also am the Senior Responsible Officer for the very significant transformation programme that we're taking forward across Staffordshire and Stoke-on-Trent. And I've got a short presentation that I will run through. I'm also joined by Simon Whitehouse, who's the Chair for the Urgent and Emergency Care Board, which is largely where we coordinate our operational and performance challenges, of which we have many at the moment. And Steve Fawcett, who's the clinical lead for the Urgent Emergency Care Transformation Programme. So if it's okay with you, Chair, I'm just going to run through 7 slides. There is a paper in the pack, and I'm just going to pick some of the highlights. I will do this very briefly, and then we can get into the Q&A as you suggest. So Jenny, I think you're running the slides for me, aren't you? Thank you. What was the STP, the Sustainability and Transformation Partnership, pre-COVID had a very challenging set of ambitions around how we transform care and the experience of care that our citizens and our patients experience. And that was picked up by the Integrated Care System, which is the successor to the STP. The consultation was paused when COVID struck, so we did a lot of the engagement around the programme in the summer of 2019. COVID struck, and in March 2020 we paused all consultation and engagement, very much in line with the national directive, so we could focus very much on our COVID response. It's now time to stand all of that up again and to re-engage with our population around those changes. Now, clearly a lot has changed during COVID, for the better and for the worse. So rather than just assume that we pick up where we left off in the summer of 19, we want to re-engage with our public, talk about those changes, their experience of that, and see how that then actually shapes what we will be consulting on later this year and next year. But we've also, rather than trying to do everything in one go, which is what we were looking to do pre-COVID, we've actually broken it down into phases. And one of the most significant elements of the engagement consultation will be around urgent emergency care, and obviously understanding people's experience of how that works for them. We do have a very fragmented urgent and emergency care system with different points of access, and if people can't get what they need and they want quickly, they will often default to A&E, which is something that we do see across all of our A&E departments. So it's very much about a new model of care which looks at how we simplify how people access care, and so that people can get the right care the first time, rather than having to knock around the system in the way that's happened before. And there are lots and lots of ways that people actually enter and engage with the urgent emergency care system. It's very much about improving outcomes as well as people's experience of that process. Next one, please, Jenny. So in terms of the temporary service changes, which no doubt committee members will be familiar with, we've talked to you about this before. These are the main changes that were made during COVID. Temporary closure of the Cannock MRU, which is still closed. Temporary closure of Leek MRU, that opened again in June 2021 when it was safe to do so. We reduced hours in a slightly different model. Minor injuries units that Royal Stoke has redirected to the Hayward Minor Injuries Unit, that remains in place. We had an expansion of the hours and clinical support at the Hayward MRU to support that change. That was nationally directed at the beginning of COVID, so that we could actually have as many staff in one place delivering care as possible. And then the county hospital in Stafford, cardiac arrest patients are taken by ambulance to Royal Stoke, so that remains in place. So they were the main changes that were made during COVID. Next one, please, Jenny. So in terms of why do we need to do things differently, we have had challenges across Staffordshire, particularly in the north, around long waiting times. It has been a long time pre-COVID that our main providers were able to meet the 4R target. So we have had challenges. COVID has sort of exacerbated some of those problems, and no doubt any questions around that, Simon and Steve will be well placed to pick up. We've also had a bit of an issue around a clear offer. I think at one point we had 11 access points to urgent and emergency care, and pre-COVID there was a national move to try and simplify that for people to put your resources in one place so we can give a better offer to people, and that's very much part of the model of care we'll talk to you about shortly. Confusion amongst the public around where to go. I've lost count of how many communiques we send out asking people to go here, to go there, to go elsewhere for their care. People often just will go to A&E, and that's a particular problem that we've had, particularly in the north at University Hospital of North Midlands. We have a real shortage of specialist urgent emergency care clinicians, and we are having some real issues at the moment. We had workforce problems pre-COVID. That's been laid bare and exacerbated by COVID. People are tired, exhausted, and we're very much feeling that at the moment in terms of burnout, and in terms of sort of people needing time off to recover, which is impacting at the moment. And clearly people have wanted time off over the summer. We asked people not to take leave during COVID. They're now taking that leave, and we have had some issues around over the last 6 or 7 weeks in terms of staff absence. National targets to deliver. We've got we've had, as I said, problems around the 4R target and meeting that. That's people being seen within 4 hours when they arrive at A&E, but we've also more recently had problems around things like ambulance handover times. I think one evening we had something like 70 ambulances waiting more than an hour at the Royal State Hospital. Not a good place to be. So again, we will be engaging and consulting with our public around how we improve all of that. Primary care colleagues got particularly concerns they've raised with us around access to general practice, which again is something that's very much built into the model of care. And the evidence base, there's a very strong evidence base for what works, and lots of work done nationally around how we have a consistent offer, irrespective of where you live, so people get what they need when they need it in a timely fashion. So we need to do things differently. We have a fragmented and sometimes dysfunctional system that we need to improve. Next one, please, Jenny. I'm not going to go through this slide, and this might be something that Steve can pick up once we finish the running through the seven slides. But in terms of simplifying access, it is a very complicated system. We want to make it easier for people to navigate, as well as people referring people into that system, GPs, for instance, and our 111 service. And urgent treatment centres will very much be part of that offer, having a small number of urgent treatment centres so people don't need to go A&E, they can actually get what they need from a UTC. And there are lots of codependencies as well. Many people who do use our urgent emergency care systems don't have a physical health issue, they will have a mental health issue. We know the vast majority of people that use our urgent emergency care services are frail older people, many people with a long-term condition. Because of our pressures in urgent emergency care, that has a spin-off knock-on impact on elective care, and clearly we have a very long waiting list we need to make some inroads into reducing. And if we've got lots of urgent care pressures, it makes it difficult to do that. There are knock-on impacts on general practice and on social care. So this is a really, really key issue that we need to address. And we will be picking up the things we talked to people about in the summer of 29, looking at how things have changed, and that will very much inform the consultation we will do later in the year. Next one, please, Jenny. So in terms of understanding what's new, there are lots of ways that people can get involved. I'm not going to go through all of this. This information is readily available on our various different websites, but a very proactive approach to actually encouraging people to attend the events that we put on. The engagement will start now and run through till near the end of October. There will be events that people can register for and can attend, but clearly people will feel anxious about coming out and doing that. And many of the people that use our urgent emergency care services are vulnerable, older people, etc. We wouldn't expect them to necessarily turn up to events. So we'll be doing a lot of things virtually, There'll be surveys, and we will be proactively reaching out to more seldom heard and vulnerable groups to understand their views. So more information is available on the Together We're Better website, and the link is on the slide there. Next one, please, Jenny. And then just in terms of our journey and next steps, I'm not going to go through this slide, but that does set out where we started back in December 2016, and what we're looking to do in terms of involvement over the winter and the spring, which is the red circle at the end, so that we can sort of take on board people's issues, concerns, feed that into shaping and designing the consultation process, and the options that we will be discussing with people later this year, beginning of next year. I think that was the last slide, Jenny.
It is, yes.
Yeah, thank you. So, Chair, if it's okay with you, I'll pause at that point, and happy to take any questions that members may have.
Thank you, Simon, and be good to see the slides at some stage so we can circulate them to members, but thank you for that. Charlotte Atkins.
First of all, when you're talking about the urgent treatment centres, what will the numbers of those be? Because at the moment we have, as you say, walk-in centres, minor injuries units, etc. Is the plan to have urgent treatment centres in all those locations, or are we talking about a reduced number of locations? You talk about ambulances waiting outside hospitals. Well, I think it makes a joke of the concept of integrated care when ambulances can be waiting outside, say, the Royal Stoke Hospital, not for 1 hour, but for 3 hours. I mean, it just shows it's an absolute joke just talking about integrated care when that sort of thing happens, particularly when the ambulance service is under so much pressure, both in the West Midlands and nationwide. I mean, just ridiculous. And you talk about confusion over what's on offer at different places. Well, I'll tell you what causes confusion is when a minor injuries unit is no longer a walk-in centre, as it isn't in Leek, because people have been turned away because they haven't got an appointment. Well, the minor injuries unit always was a walk-in centre. In theory, the hours go on till 5 o'clock as opposed to the normal 8 o'clock, but in reality, people are turned away at 4:30. You know, that is what causes confusion, is the service that has been diluted and diluted by your organisation. So what I want to know is whether the community can rely on having urgent treatment centres where they presently have a centre, and what are you going to do about the waste of ambulance time, paramedic time, waiting outside hospitals? And thirdly, what are you going to do about ensuring that the minor injuries unit at Leek, which has always been a walk-in centre, is a walk-in centre and not one where people are constantly being turned away to go off to Hayward when they have no transport and no means of getting there? Thank you.
Thank you, Councillor Atkins. So I've done most of the talking so far. So in terms of maybe, Steve, if you'd like to pick the UTCs one up, and then ambulance handovers as well, while you're at it.
Yeah, for sure. Thank you, Marcus. My name's Stephen Fawcett. I'm a GP. I'm also the medical director for the CCGs in the north of the county. The UTC element's complicated, and it's actually one of the major elements of the engagement and will be of the future consultation. The UTC specification has been updated actually in July this year, slightly earlier this year, and essentially what we know is that UTCs will cover a population of between 250 and 300,000. They will need to be organised to have a certain number of features, so they'll have a certain number of opening hours, they'll have certain types of workforce. There are other elements that are slightly more fluid that we can add on depending on the clinical circumstances. But what's clear is that there will not be UTCs matched up to every single walk-in service that we have currently in the county. There simply isn't the workforce or the resource to be able to do that. So what we need to make sure is that we work with our communities and, for example, with you as the councillors, to work out where's the most effective and productive places and most useful places to put these UTCs. It's going to be one of the more complicated areas that we need to work through. But I think the other thing I would say also is that the transformations around urgent emergency care are much more than just about the building blocks and the buildings and the sites. This is very much goes back to that diagram that Mark has touched on. This is very much about making sure that patients have got services that they can use that don't require them to travel huge distances. We underutilise a lot of resources that we already have, for example, pharmacists and other forms of help. In terms of the ambulance delays, they are a worry. I mean, I'm sure Simon will chip in as well, but we are working very closely with ambulance services. Our relationship with WOMAS has improved terrifically over the last 12 months. And the other thing to bear in mind is that actually we have lower conveyance rates to hospital than any other economy in the West Midlands. And that's mainly because we provide alternatives for WOMAS to use and other services. So, for example, one of the big innovations and something that we've had a lot of plaudits about is the Community Rapid Intervention Service, or the CRIS. And we are working very hard with WOMAS so that they can use the CRIS to release their ambulance crews to deal with other calls. I think we have to recognise that also that the hospital, or all the acute hospitals, are still struggling with the effects of COVID, with the effects of the infection prevention and control regimes that they have to operate, and this does impede their progress, which is why ambulance services across the country are finding a problem with ambulance handover delays. It's not something that we want, and it's something we're working very hard to try and manage, and we're working very closely with WOMAS to do that. But there are some challenges there, and we have to be honest about that.
Could I just come back, Chair? I mean, as usual, a reduction in service dressed up as transformation. I don't think anyone's going to be fooled by that. We've had a real, there's very little public transport in the more rural parts of Staffordshire and the West Midlands, and we've seen the problems created by the MIUs being closed and people having to get to the Hayward. So increasingly what happens is all services are going to be focused on urban centres. And from what you've said about the UTCs, then clearly a lot of MIUs, including the one in Cannock, which is not even reopened yet, are going to go. And, your comment about the ambulances, I think, is disingenuous. We had a presentation from Mark Doherty at the Staffordshire Moorlands Health Committee, and it was absolutely devastating, the fact that the ambulance service is stretched in such a huge way. And I find it incredible that the NHS can't get its act together to actually reduce that wastage of person power and vehicles.
Just, can I come in there? I think we're sort of semi-wandering somewhat off the subject, because this isn't a scrutiny of the ambulance service. This is more a scrutiny of the process that is going to go forwards in terms of the urgent emergency care. Having said that, Steve, can you just give some comments on what Charlotte has said, and then I just want to bring that to a close, because I do want to come on to the ambulance service later.
Certainly, Chair. I think the observation about MIUs is important. I think we need to bear in mind that we need to develop a different offer at the community level. That's, if you remember, the DMBC, which is slightly separate from this, has already worked out, or has already described what that community offer needs to look like. So for MIUs, for some MIUs, if it's not going to be a full-blown UTC, then we need to be developing the primary care stroke community offer that allows patients to get non-elective or urgent needs dealt with there that are appropriate. I use the word as appropriate. And I think the other bit I would say about the ambulance service is that actually we're working very hard with ambulance services to make sure that they have got opportunities to release their staff and get their staff back into circulation. But as I said, it's a work in progress. There's no question the whole system is under pressure, and I can't tell you that we will have it instantly solved. But we are working together in partnership, and we're also making sure that patients are safe, and that's really important.
Simon, did you want to come in?
I was going to, Chair, sorry, Simon Whitehouse, Integrated Care System Lead Director. I was Chair, but Dr. Fawcett and Steve's covered the main points. I think, just really quickly, I think if we want to get into a conversation about urgent care performance and Scrutiny wants to get into that space, then we'd be more than happy to come back with the ambulance service and with UH&N colleagues to get into that discussion. I think that would be probably a useful discussion to have. But I think your point was well made in terms of the challenges of transformation versus that area of performance. But as Steve has said, let's be really clear, we are not just sitting and accepting the ambulance challenge or the UH&M performance challenge as a that's okay for patient care. Anything but. We're absolutely in the space of partnership working to make that as good as we can against the backdrop of the challenges that are multifaceted.
Thank you, Simon. Before I bring in Jill Hood, could I just have two confirmations, please? One is that empirical data like journey times and travel times will be taken into account in any decisions made. I think it was implicit but not direct. And second of all, that no decision has been taken on any of the building blocks, MIUs or otherwise, until the consultation and the business cases have been completed.
Correct.
Yeah,
thank you, Jill Hood.
Chair, in terms of that second point, yes, you're absolutely right to point that out. The changes that were made during COVID were temporary, and we are still in the middle of a pandemic. We're still seeing 30-odd thousand cases a day. We've got over 8,000 people in hospital across the country. We are not out of the woods yet. And we are looking at an incredibly difficult winter. So those were temporary changes made to enable us to manage COVID. No changes will be made permanent, certainly, until after we've formally consulted. This is very much an engagement to inform the consultation that will be happening probably at some point in next year.
Thank you. Jill Hood.
Chairman, my question has been answered. Thank you.
I'm sorry, Jill. So, where do we want to go to next? Keith.
Thank you, Chair. I'll try and stick to the process itself and everything else going on. I have at previous meetings said that I still don't understand why you, by concentrating all your services in urban-based areas within the county, but why do you send people who have other medical conditions straight into the fire in relation to where other viruses are in large numbers and where people will get potentially infected, not just with the coronavirus, but with the coming flu season and everything else. And I still yet don't understand how, by almost creating more work than necessary for the primary care system, why the primary care system themselves can't have some sort of caring processes and systems within their own ability, but also within centres such as Leek Hospital, whereby people will no longer need to travel to the urban centres where people are naturally ill. And I just still don't understand why that seems to be the priority in relation to these transformations that are going on. My own experience about this is my daughter had a knee injury. It took 8 weeks to realise it was a crucial ligament that was torn, and then she had an appointment down in Cannock, and that Cannock appointment was then cancelled because the equipment failed, and she's still waiting to this day. So I don't see how this potential work is improving. I certainly haven't experienced it myself. And then my final question, the second part of the question is, in terms of the actual consultation period itself, it seems quite short. These are going to be very important decisions that are going to be made within the county, and particularly within the north. Surely it would be better to try and get more engagement. I know that you're doing quite a lot of things with the virtual meetings and with the online survey and other things like that. I would strongly suggest that more information out to parish councils and to also primary care situations and their own committees. I assume that they're being involved as well. So I just would like to try and find out why it's all being pushed into such a short time scale, when really we need to try and make sure that the decisions that are being made in any transformation make sense. And to me at the moment, and to what I've witnessed while I've been on this committee, they do not. Thank you, Chair.
Thanks, Keith. Simon.
Chair, if maybe I can pick the second point first, and then Steve can go back and pick the first point up. this isn't the consultation. So this is a pre-consultation engagement process. So we did an awful lot of engagement in the summer of 2019 that would inform a consultation that was due to take place in 2020. The pandemic hit, we had to pause all of that. So what we're doing is, rather than assuming that everything that people talked to us about in the summer 2019 still stands, we're actually doing some further engagement now that will then inform the development of the pre-consultation business case that we will be formally consulting on. So the formal consultation, in line with our legal responsibilities, will be a proper 3-month consultation. This is just the pre-consultation engagement, just checking out what people told us in the summer of 29 still stands, and also just building in the experience of people's access to experience of using services during the pandemic.
Going back to the first point, Chair, the point I wanted to make is that the Councillor's challenge is absolutely right in that what we really would need to be focusing on is the pathways for care. We focus a lot on the buildings and so forth, but actually one of the bits that clinicians in primary care are particularly interested in is, what do we do about frailty? How can we keep frail patients away from hospitals? How can we look after them more appropriately at resource in the community? So that doesn't need UTCs, that just needs different ways of working and different types of clinical support. It comes back to my point to Councillor Atkins, is that we talk about UTCs, but actually we also need to be thinking about what the community offer is. What can we do now that we're starting to do primary care and other things at scale, and how can we leverage some of the new roles that are coming into primary care, so people can be treated at either at home or indeed more locally. And again, that it comes back to, what do those community hubs look like? So those are very much in the forefront of all the clinicians thinking about how we develop urgent emergency care. It's not just about the shiny A&Es and the with the bright lights and so forth. This is very much about what the community offer is, because we know that a lot of people go to EDs who simply don't need to be there. Some do, and that's absolutely fine. But actually, if we could offer something more appropriate locally, then that's clearly the best way to go. And that model is the one that we're working hard to work through.
Keith.
Yeah, thank you, Jay. Glad to hear that you are looking at the ways of keeping people away from the major hubs, which is what I've been trying to make sure people are aware of, and I hope that the consultation takes even more people away from hospitals and alleviates some of the problems around the emergency and accident centres as well. In terms of the consultation, yes, fine if it's a pre-consultation, but I just want to try and make sure that it's spread as wide as possible in the limited time that you've got. And I do think that there's other structures, districts as well. We've got 8 districts in the area, in the county, and others that they have at least some idea and some concept to have a feedback into the process, because I think it is really important that we concentrate on trying to make the medical and the processes involved far simpler than they are at the moment. As the example I gave earlier, it just seems to be that things seem to be getting more complicated, not less complicated, and we need to move away from this idea that the NHS is not transformable. I think it has to be transformed, and the services have to make far more sense than they do at the moment. Thank you.
Steve.
Thank you, Chair. If I could just confirm that, yes, Staffordshire and Stoke-on-Trent, yeah, it is a big place, and we have done lots of in previous consultations, lots of focus on engaging with local communities and stakeholders, including the district. So it will be wide-ranging, and looking at the list of consultees in previous significant transformation programmes we've consulted on, it will be extensive. And clearly, if committee members are keen for us to consult with particular groups, or we can build that into the process. So we will leave no stone unturned and make it as wide-ranging as we need to be. This is one of the most important consultations we will be doing, one of the most significant transformation programmes we will be undertaking. And whilst I wouldn't say it's necessarily once in a generation, it will be very, very wide-ranging in terms of how care is delivered, how people access care, and the clinical models of care. It will also inform our workforce modelling, etc., going forward, and it will very much be a clinically led process. So it's going to be pretty extensive. We need to get it right.
Thank you. If I can just let me take Chair's licence and follow up a couple of things, if I may, please. I understand this is a pre-consultation engagement session, but I also noticed that there is actually no face-to-face engagement. It's either online or via surveys or virtual. And did you give any consideration to any face-to-face sessions? That's the first question. And the second question is, what involvement has our colleagues and friends at Healthwatch had? If you could answer those two, I'd be grateful, please.
Thank you, Chair. Maybe if I just bring Jenny in to answer those two.
Yes, so I'm Jenny Fullards. I'm the Communications and Engagement Lead for this. So we are considering face-to-face engagement. So the presentations details, the virtual engagement events that we're planning and the survey. We are also approaching a whole range of different community groups and offering them presentations or the opportunity to speak to us about this, because we do want to make it as wide-ranging as we can. We are very aware still of the social distancing measures, particularly in our wards and our departments. So we are working with the clinical teams and the communications teams in those trusts to look at what face-to-face opportunities there are that we can safely do. So we are looking at that at the moment. And we are continuing to have conversations with Healthwatch as part of developing not just this pre-consultation engagement process, but the wider process. And as we move towards developing proposals, we will be linking very closely with Healthwatch as one of our assurance partners.
Thank you. Just picking up one of the other elements, please. I think that as an outcome from the overall process, not necessarily the pre-consultation process, but the overall process, I think that there is a need to end up with a common explainable offer to residents so that they understand where and how to access the system, particularly when you talk about new ways of working and new pathways. Because actually, if they don't understand how to access the system, they'll carry on doing what they've always done. Why would they do anything different? And second of all, I would like to feel that if there is change in the system, and there needs to be change in the system, because I think, Marcus, you indicated that it was fragmented and dysfunctional, so there needs to be change in the system. Then the change needs to be linked to outcomes, i.e. improved waiting times or reduced waiting times, improved health outcomes for residents. And I would like to feel that it wasn't just a moving of chess pieces around the board, but actually residents could understand clearly what the benefit was to them.
Yeah, thank you, Chair. Maybe Simon, do you want to pick that first one up, or then maybe Steve can talk about the benefits?
I mean, I think, Chair, yeah, you and Cabinet and committee colleagues have made really important points around that. I think what I've heard this morning is that, as ever, there's a really important bit of this ends up not just being about buildings or sites, that this needs to be around what the pathway looks like for urgent emergency care services for residents of across Staffordshire, and that will vary in different parts of Staffordshire, and we need to make sure that we get that bit right, which is the district and borough link as well with localities and with local geographies, to make sure that we get that narrative bit. If we carry on doing what we've always done, we'll get the same outcomes. So waiting times and delays will continue to increase. COVID has taught us some good things, but also there's been some bits that didn't work as well as we would want it to. And it's really important now that we come back and revisit all of that as a pathway in its entirety and not just bits of it. So, you know, I've heard Steve talk a lot around what's the community-based offer, what's the offer in conjunction with the ambulance service and with the rapid intervention service, and how do we scale that up and create the capacity in the right place. I think one of the key aspects that Steve's talked about is, and Marcus has touched on, is the partnership between providers of urgent and emergency care is in a much stronger place than it's been previously in the system, and we have to maximise on that now in terms of what can that look like. But we have to do that with the population and with local residents to make sure there's that understanding of ease of access, equitable access, needs-based driven services in a way that makes sure that we reflect the changing demographics and challenges across the population of Staffordshire.
And just for me as a clinician and as a service user for that matter, I've been to ED a few times recently with broken bones. The outcomes that we want to see is actually patients having a better experience. Going to ED or going to any big shiny hospital or community facility is not always the greatest place to be. And it comes back again to that diagram. It's very much about making sure people are informed so they absolutely understand where they can go to get what, and they get it quickly, they get it effectively, and they can get on with their lives. We want the other side of it is about making sure that people who are carers, who are looking after, know exactly what they can do for their loved ones, so they're not sitting in limbo wondering what the right way is. And that again comes back to what the community offer is. So it's not just about the venues, it's about what are the overall services and packages around them, and making sure they get care quickly, they get it effectively, and they get it without the hassle that they currently experience. That's it for me. And just as a final word as a GP, is trying to make sure that people, when you're asking for help and you're trying to navigate people through the system, it's a very clear system so that there's no ambiguities. And I think the strategy that's laid out here absolutely emphasises and majors on that, and that's absolutely the right way to go, in my opinion.
Thanks, Steve. Just a comment from me, just back as a challenge, is that whilst those are important outcomes for residents, equally how quickly they're seen, being able to access GP appointments and all sorts of other things is also tangible outcomes. And I think we probably need to be bolder, accepting that we're not going to achieve every one of them, but they are an aspiration to achieve, might be a useful tangible outcome rather than how quickly you can navigate the process. But just I think that probably takes a bit more courage, probably, and I'm sure that's probably an outcome from today. Can I just leave those comments where they sit, and I'm going to go to Janice and then on to Paul.
Yeah, thank you, Chair, and good morning, everyone. Certainly, what I'm hearing on there, from my own personal perspective, is getting some real clarity on paper. I think that a mapped service provision would be helpful to be able to see it diagrammatically, and for want of a better word, looking at the catchment. So we've mentioned about how many people might be coming under that provision, but a radius is to say what is actually available as a service and who that is supposed to be aimed at would be helpful. Certainly I've been able to bear witness to some innovative and efficient provision of late, and I think it's important that we capture and retain some of that. But how that is accessed is critical in a timely fashion, and I think that being able to have some more clarity on how we can try and relay that back to people who we're hoping to engage in this consultation process would be extremely helpful, whether that's back in our divisions or in the districts that some of our colleagues might be able to do so as well, would be really helpful sooner rather than later. Thank you.
Who's picking that up?
I think that was probably more comment than question, but I think I would entirely agree in terms of simplifying things, mapping them out so people understand how to navigate the system. My comment around fragmented and dysfunctional is services are somewhat fragmented. If you use a service and don't get what you need when you need it and can't navigate the system as a service, this doesn't work for me, then clearly we need to do some work on that dysfunctionality. The ambition of this programme is very much to do what the Councillor just said, is to simplify it, have very clear pathways of care, not just for the people navigating it through their own steam, but also the people referring into that system. Because I think it's not just patients who get frustrated. I think GPs and other clinicians referring into the system, people working in the urgent care system also struggle. If, for instance, an A&E clinician has a patient that doesn't need to be admitted but can be seen in a community service, not being able to access that quickly is going to cause them some problems and concerns. So this isn't just about the patient experience, it's about people who work in that system as well, who are probably as frustrated as patients are and not being able to do what is in the patient's best interest in a timely fashion. So that's very much the ambition, yes. Steve, you may want to add to that.
No, I mean, I was trying to make what you've said much more clearly is about it's also about how clinicians work with the system, because as you say, it can be confusing for them and they end up going down different routes and spending an awful lot of time which actually they don't need to. So the system has to be about making it work for everybody, the patients, and I mean clearly the patients and the services are key, but actually we also need to make the best use of our workforce and our other systems. You know, a lot of the stuff that we do now can be inefficient. And this review is about creating efficiencies and giving clinicians a very clear way of doing their work and knowing that they've done the right thing, because it's not always clear now.
And if I could just maybe add to that, Chair, it's not as if everything is broken and doesn't work. We do have some examples we can build upon. For instance, the Community Rapid Intervention Service, the CRIS, which is operated as a partnership between UH&M and Midlands Partnership Foundation Trust, who provide community services, works incredibly well at the front door in terms of stopping people who don't need to be admitted to hospital. They can actually be managed in the community or a more appropriate setting. So the CRIS has worked really, really well and has taken some of the pressure off at the front door. And also working with the ambulance trust as well around sort of category 3 and 4 patients, diverting them into the CRIS so they don't need to go to A&E. That's worked really, really well. It hinges very much on a timely response. If you can't get that response in place in the first hour or two, then patients often are transported. So, but that's working well. And as a commissioner, we're looking to commission more of that. We've also got the discharge to assess service, which again is, you know, far more people being discharged home from hospital in a much more timely fashion, which frees up beds for people who do need to be admitted and receive that acute medical care. So we do have things that work well, partnerships between NHS providers and also the local authorities and the third sector. But there's clearly more we can do. But I think the experience of that, both before the pandemic and during the pandemic, I think gives us some you know, we know what good looks like, and that will help us to inform the engagement with our public and clinicians and other stakeholders, and also the consultation process. So we're not doing this completely blind. There's some stuff, some good stuff that we can use to inform that process.
Thank you. Just before I bring you back in, Janice, I believe the Cabinet member just wants to add something. Do you?
Thank you very much, Chairman, for the opportunity to speak. Good morning. I'm Councillor Julia Jessel. I'm Cabinet Member for Health and Care. And I will say my background is I've worked in urgent care in Derbyshire for a good number of years. And the problems are still the same now as they were 10 years ago. I think the one thing that the NHS always falls into the trap of actually looking at things from the patient's perspective. And patients go to A&E department because they can be seen, be treated and come out. The concern I have is that there is, you know, evidence that urgent treatment centres work, but they need to provide the same kind of procedures, processes and times for the whole of that network. Whereas I think you're at dire risk of replicating what is available at the moment, which is a bit patchy. You can get certain things done at one centre, but not at another. So I think there needs to be an understanding of what is provided at one has to be provided at all. The other thing is that what actions are being taken to turn people away from main A&E departments, because otherwise they will still turn up there. Patients are like water. They'll find a way through. And I mean, one comment has been made. I had a similar circumstance. I went suspected broken foot to a GP. It took 2.5 weeks. I had an x-ray and it was 2 weeks before I found out the result. Had I have gone to A&E, I'd have got that in 2.5 hours. Now, our patients are our customers. And they pay for the NHS. And I think, gentlemen, I would ask you to put yourselves in the position of patients. And patients will go where they'll get that assessment and treatment if necessary. It's very difficult for A&E staff to actually turn people away for very obvious reasons. They're always fearful that they'll get sued because something may go wrong. So unless you address that, have you thought about, and I know it works in certain parts of the country, having minor injuries urgent treatment centres parallel on hospital sites, so that if anybody walks through A&E, they've got to just go to the next door. Are you honestly going to turn somebody away from Stoke and send them to the Haywoods? I don't think that's going to happen. They're going to treat them. So I think there are some fundamental flaws. I've been there, I've done that, and I've done the same thing 10 years ago. Please don't make the same mistakes.
Thank you. I mean, I think in response to that, Simon and Steve, maybe if you go, there's probably a couple of comments I'd like to make as well. So, Simon, if you want to start.
Yeah, so I'm sure Steve will come in on some of that. And to be so, thanks, thank you, Councillor, for the comments. So, in terms of the first bit, equally, I'm a resident of Staffordshire, as is my family. So, absolutely, I've had the experience of using this from a patient and resident's perspective, not just from a senior leader's perspective. I think to your first point around the consolidation of service offer in an urgent treatment centre, I think that's exactly what this part of the conversation is about, actually. It's about moving to a position where we can have both the scale, the workforce, the access to the other services that support the delivery of that care, so that we can offer something that's more consistent, more standardised, and fits with that simplifying the urgent and emergency care pathway. I think Steve will probably come on to the second bit more, which is around the how do we manage the flow and how do we get the right patients to the right place at the right time. You're absolutely right in terms of patients will turn up where they think they can get the right service, but quite often, so the work we've got to do is make sure that the right service is where they go to the first time. And keep working with them on that. And there's a number of initiatives that we're starting to put in place to look at that. But in terms of your first bit, that consolidation, that stabilisation and that consistency of offer is absolutely a fundamental part of what this process is about.
Yeah. And just to add to that, I think your observation that people always tend to go where the light's on, where they can get service quickly, is true. And that's been one of the problems or the challenges that ED have faced for probably the last 10 or 15 years. So I think your previous experience is probably absolutely right. But I think we're also very cited on that. And the whole ethos of the programme is to direct people away from EDs where it's safe and feasible to do that. Now, part of that solution is about UTCs. I won't bang on again about community offers, but I would slightly bang on about the 111 offer. I think one of the things that COVID has taught us is that people are seeking care in different ways. We're seeing that in all sorts of different walks of our services, and in primary care, in community care. I mean, for example, hospitals do a huge number of remote consultations, which they never did before. And it's not for everyone, and we know, it's horses for courses, but I think people are much more willing to use online and digital solutions and telephones to find out where they need to go. And that's where 111, and particularly the clinical assessment service that sits behind 111, that can direct them into the right part of the service, is absolutely key. And again, if you go back to that diagram that was in Marcus's slide deck, it gives you the centrality of 111. That wasn't an offer really that we had 5 to 10 years ago. That's something that's become recent and is now being invested in and promoted and expanded at an ever increasing rate. So I know the council will be cited that we've recently starting a trial of 111 kiosks in ED, again about helping patients get to the right part of the system even when they've arrived in ED. I would just touch on the comment about co-location of UTCs at acute hospitals. The revised UT specification pretty much suggests that we should avoid doing that because they want UTCs to be much more community facing. But nevertheless, there is the option there is the way of working about having a primary care offer at ED, because there will still be some patients that arrive there and need that sort of input. But actually, our real drive is about getting patients to other services that if they don't need ED, they should be somewhere else to be getting their service, because they're likely to get it quicker. And that, truthfully, and there was a comment from an earlier councillor which I wanted to highlight, is that EDs are big groups of people. It's safer to be somewhere else. So, in terms of patient safety, it is also something that clinicians would be keen to do, is to decompress ED and get people to other services which are less crowded and less likely to pick up infections as a side event.
Thank you. I'm going to try and bring those two sets of questions together. Janice, do you have anything you want to come back on?
Just briefly, because I think we are making the same point, but it is a case of making sure that message is clear. So in terms of being able to map those services so you can see quite clearly throughout the geography of it, what is available and where and to whom would be really helpful to be able to get that message across. And certainly with regard to the pathways, that is the crucial part. And just picking up on that last point, you know, if you make a phone call to treble one, patients don't necessarily see the difference between what is urgent and what is emergency. And if you want that assistance, having a phone call back 6-8 hours plus later isn't necessarily supporting that. Thank you.
Julia, do you want to add anything to that? Marcus, is there any need to come back on those comments noted? And
just very briefly, I mean, as Simon said, I live in Staffordshire. My children were born in Staffordshire. I've got elderly relatives that live in Staffordshire, and the frustrations that our patients experience on a day-to-day basis, we also experience. So it's not as if we're sat somewhere else, sort of making decisions around patient care and pathways. Yeah, we live and breathe and experience it both as officers working in the system, as well as citizens and patients receiving care. So I would want the committee to be assured that we do very much, that patient perspective is shaped by our own experiences as well, and would want you to be assured that, you know, I would want your mum, your or anyone's mother, father or relative to have the same experience as my mum or relative. So yeah, this is very much about working with our communities, understanding the experiences they've got and doing everything we can to improve that experience and those outcomes. So very helpful feedback and comments, which we will use to shape the engagement process and the consultation going forward. So thank you for that.
Paul Northcote, good morning.
Good morning, Chair. Thank you. Good morning, everybody. I've got two questions. The first one relates to the overview part of things. With all the consultations and engagement with stakeholders and the public, how will you measure how effective you've been in terms of encapsulating the right information to take forward in terms of shaping the NHS? And the second question, well, it's more of a comment really, and I'm aware that people chip in with anecdotal scenarios, but I think this one's worthy of mentioning. Last weekend, there was a youngster in Newcastle, not a million miles away from the NHS hospital services, that broke his leg and suffered a compound fracture of his leg during a football match where the bone, for those that don't know what a compound fracture is, where the bone protruded through his leg. They called for an ambulance and we're told not to move him because of the possibility of bleeds. And this young man was waiting, bearing in mind that this is in the centre of Newcastle, not in the rural area, was waiting over an hour for an ambulance to come to collect him. That clearly is unacceptable. Once he got to the hospital, his care was fantastic, but just to make sure that when you're having these discussions that you bear in mind in a modern world, in an urban area, as well as I'm usually banging on about the rural area because that's most of my constituents. But just to bear in mind that these things are happening now, live as we speak, and I wouldn't want that to be lost in the mix. Thank you very much.
Marcus.
Thank you. I think the first part of that was very much a question around the consultation engagement process. Jenny, did you want to maybe pick that one up, given that you're sort of leading a lot of that work?
Yes, really good question. So we do a independent report which pulls together all of the feedback that we receive. So that's coded and analysed, and that report will go to the clinicians and the operational leads that will be developing those proposals. It also goes to the various governance routes through both the trusts and also the clinical commissioning groups for review. So we look very closely at the feedback that we've received. We look in terms of the demographic profile of who has responded. So we do capture demographic information to check that we have covered all the areas that we need to do, both geographically, but also in terms of our demographics for our local population. So we do a midpoint review as part of this process, and I know there was a comment earlier about the length of time for this work, for this sense check engagement. So as part of this, we will take a view as to whether or not we do need to extend, whether we've had sufficient responses to help us inform the proposals over the coming weeks. But that report will be shared not only with the Scrutiny Committee, but also it gets put on our website and it's published so that the public can see it as well. So we will go through that process over the coming weeks and months and aim to share that information as well as we go forwards to develop those proposals.
Thanks, Jenny.
Paul, do you want to come back?
Thank you very much for that. Yeah, you preempted what I was going to ask him. If you could share that information, that's great. I'd look forward to that information coming forward. Thank you.
And Angela wants to come in on this specific point.
Yeah. Thank you very much, Chairman. Just to mention, actually, I'm pleased to hear that Health Watch is going to be involved in this. And if they're going to do face-to-face meetings, can I make a request that they actually publicise it fully? Because I've been to meetings with Health Watch when it's been a public meeting and there's only been 6 people there. So if we want to hear the voices of the public, can we make sure that they put their voices out correctly? Thank you.
Someone for Jenny?
Yes, so absolutely any meetings, we will promote them. I'm not sure whether they will be the actual meetings that will be held publicly. I think those will, face-to-face. I think it'll likely be virtual for those bigger meetings. But I think what we're keen to do is try and get into perhaps the different clinics and perhaps the different communities and actually just understand how do we reach people to perhaps get their views who perhaps wouldn't take part in a survey or those virtual events. That's what we're exploring at the moment. But any events that are held, absolutely, we will work to promote them.
Anne, are you happy with that? Yes, thank you. Richard, your turn.
Thank you, Chairman. Really, it is a comment which encapsulates possibly what a lot has already been said. And I think Councillor Jessel possibly hit the nail on the head. Patients are customers in the whole process of this. And it's interesting what you're presenting to us today. But it's sometimes you've got to listen to other people to make the judgments, not think that you're getting it right by not actually listening to the issues. And you need to get that message across. That is my take on it from hearing people complain about it in such that, yes, we're living through a pandemic, but there's a lot that seems to be happening elsewhere that's getting on with things, yet we seem to not necessarily be getting on things in processing it as we are through our practices in what we've been discussing. So it's really just a comment and food for thought.
Thank you.
Simon, the last comment is with you then.
So, I mean, the last 2 councillors' comments, let's be really clear. You know, nobody working in the health and care system across Staffordshire or Stoke-on-Trent wants patients to be waiting unnecessarily, wants patients to have bad experience of care. Everybody's absolutely focused on getting improving the access, improving the timeliness of response, and focusing on the best outcomes we can for the population that we serve. So let's be really clear in terms of that as a just a clear line in the sand around that. I think let's also recognise that we haven't got everything working as well as we would want it to do across Staffordshire and Stoke-on-Trent. And colleagues are right. We need to bring a real focus to making that change in the right way. And we need to do that in the right way. And I'd be really keen to explore what's the art of the possible of what we can do faster because and quicker, because there are times when we want to bring about some of the changes and the process approach and the engagement approach makes that feel more drawn out than it does in other areas that I've worked. But equally, want to get that right with local communities, local council, local people in terms of bringing those changes about. And I guess the final point then from me is so absolutely, patients are the consumers of the service in terms of the NHS and social care. But at the same time, I think we've got a mutual accountability and mutual responsibility in terms of helping colleagues and helping people to use the right services at the right time in the right way. I don't think it's just a consumer-driven approach in the same way as retail is from a customer perspective, but we have to get the access right, we have to get the clinical input right, and we have to get the outcomes right so that we can meet the needs of the population. But it needs to be really important that we're driving this by meeting the clinical and care needs of the population that we serve.
Steve, it turns out the last word is with you.
Yeah, and I suppose just following on from, well, actually, no, it's going to be Marcus, but just following from Simon's point, this is a clinically led programme. There are clinicians running throughout all of the elements of this work. And I know, you might regard us as being CCG sort of employees, but actually I'm a frontline clinician. I see patients every single day, as indeed all the clinicians on this programme do. We're very aware of the frailties and the successes of the system. And we're very clear that we want change, but we're very clear that we also want to listen to patients and take patients with us on this journey, not just impose something. And that's very much what this whole programme's about. This is about trying to listen and trying to understand the art of the possible in terms of the resources we have and the way that we can deliver the best quality care. And I suppose that's why I just want to put a marker down.
Turns out the last word is with Marcus.
Thank you, Chair. It's just a quickie, really, because I think both Simon and Steve have more or less said what I was planning on saying. We just need to be careful as well around expectations. We will engage. We will listen to people. It's not a referendum on the options. There is only so much we can do with the workforce, with the infrastructure, with the resource that we have. So we absolutely want to take on board people's views around what we will be proposing to do. But it has to be deliverable, and we have to be realistic about that. Whilst the NHS has benefited this year and during COVID from the largesse of the Chancellor, these are public resources, and we have to live within our means. So yes, we will absolutely engage, we will consult, and we will look to do the right thing that will deliver the best possible outcomes. But we are not going to have a urgent treatment centre at the end in every single community, whilst we will obviously be looking to provide timely access for services, there are limitations on all of that, and we will want to be very open and honest with people as we go through that process. We're not going to promise something we can't deliver. We will only be consulting on things that we can deliver. So yes, listening to people is really, really important, but it has to be, as Steve said, the art of the possible.
Thank you. I know Richard doesn't want to come back, so on that basis, I'm going to draw this item to a close. So on that basis, Marcus, Simon, Steve, thank you for your input to this morning's discussion. Thank you for bringing forward this item, which is a pre-consultation engagement event, to the main event that goes forward from here. I think the discussion demonstrates two sets of things. Is a discussion about what the shared vision for the future is, but also what is the process to make sure that we get there and that we engage completely with everyone in our community, because everyone is and will be affected by this. But it's an opportunity to improve urgent and emergency care, to simplify and to make sure the pathways into the services are as easy and seamless as possible. So I don't doubt there is a very big job ahead, as you indicated earlier. So I think we'll just, will we note as a committee the process? Yeah, I think we're all in agreement with noting, and we look forward to seeing back some results from the process further on when it's at the appropriate time. Could I just also make a comment for councillors? There is an opportunity to take this back into the places you engage with, districts, boroughs, parish councils you happen to see or sit on, and I would encourage you to just make sure that people are aware of the consultation exercise, so all their views and voices are heard, and particularly those who are sort of furthest away from the normal places that we would look. Thank you. Can I move back? You're welcome to stay with us, gentlemen. I know that, Marcus, you're still with us for the next discussion, but you're welcome to stay or leave us, as the case may be otherwise, gentlemen. So I want to move back to item 4. which is the Difficult Discussions update. Who's leading us with this one, Marcus?
If I just say a few words by way of introduction, and then Dr. Lorna Clarkson is with me, who's the clinical lead for the process, and also Gina Gill, who's the manager that's doing the magic behind the scenes, as it were. There's a paper in the pack, and I'm just conscious of time, so I will keep my comments to the minimum. There's a paper in the pack that talks about what we're looking to do, the process. Committee colleagues will remember the numerous conversations we've had with you previously on this issue, particularly around hearing aids. So I think the paper's pretty comprehensive in terms of what we're looking to do. I'll hand over to Lorna to make some introductory comments, and then we're very happy to take any questions you might have. Over to you, Lorna.
Thanks, Marcus, and thanks, Chair. So I'll take the paper as read, as Marcus says. I hope most of this work will not be unfamiliar to most of the members of the committee. We started off on this process of aligning our commissioning policies for 5 quite controversial and sensitive areas in January 2020 with an initial phase of engagement. Those 5 areas of engagement, those 5 areas of care are around assisted conception, hearing aids for mild, non-complex hearing loss, male and female sterilisation, breast augmentation and reconstruction, and the removal of excess skin following significant weight loss. So we did an initial online and paper survey, which concluded in March 2020, and we held several deliberative events where members of the public were very well engaged and participated, I think, beyond our expectations. Unfortunately, we were then hit by the COVID-19 pandemic, and it was the decision made to pause this engagement as we focused on those operational pressures. So we are now, however, starting to move forward with this work again. It's an important piece of work to make sure that the policies are aligned across Staffordshire and Stoke-on-Trent, and that no one area is particularly advantaged or disadvantaged compared to the others. So we are relaunching our engagement. It's important that we listen to our patients and the public about whether their views have changed based on their experience of the COVID pandemic, and having heard some of the discussions around the way that people are utilising services, as you were just discussing the urgent and emergency care propositions, it's likely that they may have changed their views. So it's important that we go back and very honestly and transparently re-engage to gauge those views and understand what people are thinking. We'll then go through a further set of steps that are outlined in the paper, but around long listing, developing our essential criteria, the sieve that we put that long list through to decide what solutions are possible, what we might be able to do, what the right thing might be to do, and then to go through a process of weighting those criteria and working through those criteria and scoring. We'll, as we go through that process, we'll have a further public survey and report of the findings, and then we'll have an event for each proposal where we do that deliberation and scoring. We felt it was important to do that, to have one event per proposal, because first of all, the stakeholders will be very, very different, but also we absolutely acknowledge that these are areas where people feel very strongly, where they are sensitive, where they are evocative, and we need to be respectful of that and give people time to share their experiences and feel heard and listened to. In difficult circumstances. We've called this difficult decisions for a reason. We absolutely appreciate that. We plan to complete the process around March 22, and at that point we'll start to look at business cases for the commissioning of the final proposals. I'll stop there, but very happy to take any questions or comments. As I've said, we appreciate this is very sensitive and difficult, but we are absolutely committed to making sure that what we do commission around these things is absolutely driven by evidence of what is effective and beneficial, as well as what patients need, and that we don't discriminate against any one area advantageously or disadvantageously. So yeah, I'll stop there and invite any additional comments from Gina, and then any questions I'm happy to answer.
No, I think that's great. Thank you, Lorna.
So before I bring in Charlotte, just one point, which is I'm assuming you're going to take on board all of our previous comments and conversations about the previous session, so we don't have to just replay that one because it'll be very take a lot of time. Let's put it that way. Charlotte.
Thank you. I'm assuming that the Portsmouth scorecard is widely used by CCGs across the country. And one change you have brought in is relating to hearing aids for people with moderate hearing loss. So what I want to ask is, why was that not extended to mild hearing loss? I appreciate what it says in paragraph 4 something or other, that the evidence was less strong. But what I want to ask you, given that the Portsmouth scorecard is widely used, are there any other CCGs in England which deny hearing aids with people with mild hearing loss? If you could tell me which of those CCGs do deny people hearing aids with mild hearing loss, I would be grateful, because one of the problems that I've been inundated with is people who have been denied hearing aids because they've been decreed as having mild hearing loss, or at least in one ear, and therefore they did not qualify. It has been widely, and I'm constantly in fact stopped by people, last one just on Saturday, about how pleased they are that they can now get hearing aids. But it seems to me odd that you've added in this extra complication, which means that people who could benefit from hearing loss, and there's a huge, massive evidence about how important hearing aids are to mental health, to physical health, to dementia, development, etc. So I just wondered what your rationale is, and how the other CCGs also have gone down this route. Thank you.
Marcus.
Thank you, Chair. If I just hand over to Lorna first, do you want to pick that point up first, Lorna, and then I'll add to it if I need to.
So thanks for the question, an important one, and I think Gina may be better placed to answer the bit around the commissioning policies of other CCGs. I think we all recognise that you know, in an ideal world, we absolutely would commission hearing aids for mild hearing loss. That there is some evidence to suggest that they are beneficial across a broad spectrum, as the Councillor absolutely referred to, mental health and other things. However, it isn't as strong as that for moderate hearing loss. Unfortunately, we live in a world where we have to make difficult decisions, and we've had to do that based on the guidance that's been issued, the evidence that's out there. I think one thing that differs between the way that that scoring potentially, not necessarily the scorecard itself, but the way that clinicians and technicians within CCGs apply the scorecard, leading to different scores, may well be the makeup of those CPAGs, those committees themselves. So some have very technical groups that are all evidence research based specialists. Some have clinician groups, some have much broader groups where they encompass the voices of patients and the public as well. So even if we use the same scorecard, that doesn't necessarily mean that the scores will all be the same. There are also criteria around there around local needs, local resources, and local, trying to fit that against local priorities. So just to say, even if everybody does use the same scorecard, the scores may well be slightly different. Having said that, we absolutely, in an ideal world, would want to solve every problem for every person. But we have to make these difficult prioritisation decisions. I absolutely welcome the fact that we've aligned North Staffs to the other 5 commissioning organisations, whereby those with moderate hearing loss now are able to benefit, and that's a real step forward, and does enable many more people to access those hearing aids. But I think it is an unfortunate fact of life that we live within a system where we have to make these decisions, and for every hearing aid that we provide for mild hearing loss, where perhaps the evidence isn't as strong, that is one very strong evidence-based intervention, for example, a hip replacement or something else that we can't do. it's not a decision that we take lightly. It's not something that sits comfortable with any of us. As a frontline GP myself, I'm often asked about these things, and you know, it isn't something that's easy, but sadly it's something that we do have to do, but something that we do take a lot of care and deliberation over doing to make sure that where we can minimise the impact on people that we do.
Sorry, can I just clarify? Are you saying, because North Staffordshire was the only CCG in the whole of England that denied people hearing aids? For 5 long years, you've denied people hearing aids who needed them. Are you now saying that the other CCGs within Stoke-on-Trent and Staffordshire also deny people hearing aids with mild hearing loss? Or are you saying that North Staffordshire is an outlier in this respect? Now, could you also tell me, the question I asked was, which other CCG in England denies people hearing aids for mild hearing loss? If you could answer that question, if you can't answer it now, please send me the details, because last time I think I asked the questions, I think I had to wait about 2 months for the answer. Shouldn't be difficult for you to find that out, but I want to clarify what happens in the other 5 CCGs. Are they also now aligned with North Staffordshire, which is denying people hearing aids with mild hearing loss? Or because that would be a reduction in service for the other CCGs, and I'm sure that people sitting around this chamber wouldn't be happy to hear that their services declined because of the outlier status of North Staffordshire.
Gina, do we know the answer to the question around other CCGs?
Yeah, so there aren't any other CCGs that have taken this forward at this point in time.
Thank you. Charlotte, do you want to come back, or are you happy to rest?
Wait, I didn't quite understand. You're saying that the other CCGs are providing hearing aids for people with mild hearing loss. Is that what you're saying?
Yeah, so there isn't any other CCGs outside this area looking at hearing aids. And just to confirm, it is only North Staffordshire that has those restrictions around mild hearing loss. That hasn't been applied in the other 5 CCGs.
So North Staffordshire is discriminated against, unlike any other CCG in the whole of the country?
No.
That's a yes or a no?
No, North Staffordshire CCG looked at the evidence and, as Lorna said, went through a process with determining the relative priority of hearing aids and came to the decision that there were other things that were more important to fund, therefore didn't fund hearing aids. I think what Gina said is no other CCG in the country has actually has gone through the same process. Not to say they won't in the future, but they haven't at the moment. And the other 5 CCGs also didn't go through that process. So as the paper said, this is about looking at people use terms like postcoding. At the moment, we need to look at all 6 CCGs, the whole of Staffordshire and Stoke, rather than just each CCG having a different commissioning position. So the 5 areas that Lorna outlined earlier are where there's a difference. So what we're looking at is engaging and consulting on what do we do about that difference. I don't want to preempt the outcome of that consultation, but yeah, that's what we'll be doing over the next period of time as set out in the paper.
So let me be absolutely clear. So if you're in South Staffordshire and you have a mild hearing loss, you will get a hearing aid. But if you're in North Staffordshire CCG area, you won't. Is that the situation at the moment? Because
at the moment, yes.
This is a process that we're going through. And so at the moment, there is a difference. Although part of the policy has been aligned for moderate hearing loss, for mild hearing loss, North Staffordshire is the only one of the 6 CCGs that is denying people with mild hearing loss with a hearing aid. And as far as you know, I'm assuming that's the same for the rest of England.
Yes.
Let me bring in Anne Edgeler.
Thank you, Chairman. I find this very difficult, actually, and I can understand where Charlotte's coming from. Because, all right, I'm sat here with this in my ears because I can't, without it, I can't pick the full conversation up that's going out in this chamber. And what I'd like to ask is, if they'd been denied that, and I know it's still out in consultation, but if it comes that they are denied that, how are people with mild hearing loss going to be able to afford to buy an hearing aid? Because believe you me, I've just been through this process now as an individual, and I find the cost of hearing aids absolutely phenomenal. And all right, I'm in a position probably that I can, but I worry about to afford it, but I worry about the people that can't. And then I come down to how it affects your mental health, because believe you me, I've been in situations where I've not been able to pick conversations up, and it is quite worrying, and it does affect your mental health as well. So I worry if these people are denied it, that is just not on. Thank you.
Just let me make a comment, if I may, before you come in, Marcus. There's a fine line between debating each of the areas under the difficult decisions, and I would prefer that we took this as a point of principle, and I think the point of principle is either all CCGs could end up with the same service, there could be a differential service, and those are the two broad options as far as I can see it. But let's not sort of spend the next hour debating mild hearing loss, because that's the whole point of the consultation, is it not?
Yes, that is the point, Chair. So the issues that Councillor Edgeder raised are the kind of issues that through the engagement process we will feed into shaping the consultation that we will do sort of later in the year. The point of this is, as you quite rightly said, there are differences, and the 5 areas that are in the paper are the areas where there is a difference between the positions that the different CCGs have taken. So this is very much about I guess trying to see if we can come to the same decision for all 6 CCGs on that. I think one point to make is the CCGs clearly will, subject to legislation, will be abolished at the end of this year and replaced by an integrated care system with an integrated board and an integrated care partnership. Some of what we're talking about will not happen before the CCGs are abolished, and this will be something that the Integrated Care Board will need to pick up from the 1st of April, subject to the legislation being approved. That won't change. We will still need to engage and consult on this process. The ICB will need to pick it up. But yes, the paper is pretty clear that we want to see if we can arrive at the same situation for all of our residents. The CCGs are obviously responsible for their own patch. The ICB, there won't be 6, there'll be 1 ICB responsible for everyone in Stafford and Stoke. So, I would fully expect the ICB and the ICS will want to get the issue sorted, because it won't be 6 organisations, it will be 1, and it will want to commission and provide the same care equitably for all of its residents.
Thank you. Anne, do you want to come back? Just on that, presumably as part of any final report, you will bring forward the clinical commissioning priorities advisory groups medical findings. Presumably that's something that will be shared and publicly available.
Gina?
I suppose with the CPAG, the Clinical Priorities Advisory Group, that does feed into that process here, doesn't it? And as part of coming back through this technical process, it's about taking what the public have told us and what we've already looked at through that CPAG and using that to develop those proposals that will bring back and take that further advice from you guys on that, on what that further involvement might be. And I suppose then for you to advise on if you're happy with the information that you've been provided with.
Thank you. Let me bring in Janice.
Thank you very much, Chair. And just for clarity on my part, I'm Janice Sylvester Hall, and the newly elected member for Lichfield City North is the first point that I'm a new member on this committee, and as well are others, as I can see. And I think when we're looking at the phraseology of treated differently, it's been interesting listening to some of the debate so far, although on one specific area, that could actually be the case for the other areas, I think would be my first question. So it could be that, if my understanding is correctly, this term affectionately known as the postcode lottery of depending on where you live in the county doesn't just extend to hearing loss, it could actually be conception, or it could be one of the other items on that subject. So if you could just clear that up for me in my own mind, please. And then the second question that I got is to do with 4.8 on that list, and if you could just give a little bit more detail to what other interested stakeholders refers to, please.
Yeah, so just in terms of the first point, yes, it could be, if you have a consistent policy applied across the whole of Staffordshire and Stoke-on-Trent, then yes, it could be that people currently able to access services wouldn't be able to access them in future. Conversely, it could be that people who aren't able to access those services could access them in future. So without predetermining the outcome, yes, that's the point of the process. Gina, did you want to just pick the second point up?
Yeah, so your interested stakeholders, obviously we've got quite a variety of different things on those lists that we're looking at. So it will be people like our providers, Health Watch, looking at your very specific interest groups. So for example, your action on hearing loss, you may have people like Deaf Links and Deaf Vibes. So it is those, so I hope that answers the question, but it'd be very specific, won't it, to each of those key areas.
Janice, do you want to come back?
Yeah, it's just reassuring to know that part, because there are so many local groups and so many that are informal groups nowadays, even just that collect on social media, that can relate to each of those topics, and making sure that those are being involved, I think is very much necessary, as well as the formal groups that we know of. Thanks.
Just let me add to that, if I may. I'm not seeing any other contributors, so I'm going to bring this to a close in a second. But just let me add to Janice's point. You know, because this falls disproportionately hard on a small number of people, you know, I would like to see that all service users, previous service users, plus anyone who's previously contributed to the consultation is engaged with, to make sure that their views and voices are heard as part of this.
Absolutely, and I think as part of this process, you know, this engagement rebase we're doing at the minute over the next 4 weeks, this is on top of the information that we took, you know, and that we gathered this time last year. So that is still being taken into consideration and will still be used going forward in this process.
Brilliant, thank you. So I'm going to thank you for bringing this forward. I think we're at a conclusion on this, providing the comments from the previous item are taken on board as well, please. And Lorna, Gina and Marcus, thank you for your contribution to this morning's discussions.
Thank you, you're welcome.
Thanks, Chair.
Thank you.
So on that basis, are we going to note the process in the report committee? Yeah, I see lots of nods around the chamber, so that's fine. So on that basis, let's move on to item number 6, which is the Phase 3 vaccination programme. And I've seen that we've got Lynn with us, Lynn Miller. Do you want to just introduce yourself? And we've suggested maybe 10 minutes as a sort of opening set of comments, and then throw it open to the floor, please.
Yes, thank you, Chair. And we've got a brief presentation that we can just put on screen just to talk through very quickly. My name's Lynn Miller. I'm the Director of Primary Care and Medicines Optimisations for the 6 CCGs. I'm also the responsible officer for the vaccination programme. Dr. Paddy Hannigan has also joined us today, and hopefully Paddy will be able to help with any questions and join in the discussion as well. So Paddy is our chair, as you probably know, of the CCGs. He's happy to answer absolutely. So I'll quickly get started. Just in terms of what I want to get across today, there's a bit about this becoming quite complicated. Now, patients shouldn't feel that, but certainly it is more complex in terms of the different cohorts, the different vaccines, the different administration and storage of those vaccines that make it behind the scenes quite a bit more logistically challenging, let's just say that. So I'll give an update today around the 3rd primary dose for the immunosuppressed, and hopefully Paddy can give you the rationale for that and why it's not being seen as a booster. I can update on the booster programme, which you probably all know has started from the 20th of September, from this weekend actually. I'll talk a bit about children, both clinically vulnerable and healthy children, and how we're ready to go in terms of the children's vaccination programme in schools, just a bit where we are in terms of data, then I'll move on to the bit around questions and getting your comments and feedback. So if I go to the first slide, please. this is a totality of what we're dealing with now in terms of the different cohorts. So I'm not going to go through each and every one of these, but actually you can see that each cohort has a different vaccine, a different dosage type, a different booking route, and there's different storage as well. So I'll let you run through that in your own time, and I can certainly share these slides with you, but it just gives an idea of the logistics we're having to deal with and how we manage, say, a 17 and 3/4-year-old differently than how we would with a 12 to 15-year-old. So if I can move to the first slide, please. So the first thing just to raise is around people who are immunosuppressed, so clinically extremely vulnerable. The way that we're actually approaching this cohort of people is this is being seen as a third primary dose rather than a booster. Now, Paddy, would you just like to explain that in terms of why that's the case?
Thanks, Lynn. This comes from research where they've been tracking the immune response to vaccination. And so at the beginning of September, we had guidance from the JCVI saying that people whose immune system was impaired primarily due to medication or other therapies would be it would benefit them to have a third primary dose 8 weeks after their second dose. For many of the patients, they've already passed that time, so we're effectively going to do a catch-up piece and offer vaccination probably by two routes, either through their hospital consultant in the case of some specialities or via their GP site. There are some issues with some of the medications around timing, so we need to get it right, and we'll need the hospital consultants to guide us around ideal timing. For other patients, we just need to get them through and get them their third booster or third primary dose. The situation with boosters is not yet clear, so having done 3 primary injections, what we don't know yet is whether they will then go on and need a further booster at some point in the future. And again, that will be research-based, but we don't have an answer for that yet.
Thanks, Paddy. And you can see that Paddy's in surgery this morning, hence why there's a bit of an echo going on in the background. If we can move to the next slide, please. Okay, so we've been planning for a booster programme since the beginning of summer, actually. And what this is, a third dose of the COVID vaccine 6 months after a patient has been fully dosed. It was announced last week that all adults over the age of 50 would be eligible for a booster. And we would prioritise around risk. So a similar process in terms of how we went through phase 1. So initially, our GPs will be targeting people who are living in care homes and the older cohorts, the over 80, so we can ensure that they're protected as early as possible. It will include frontline health and social care workers, and anybody who is 16 to 49 with an underlying health condition. So this was cohort 6 in our first phase, so clinically extremely vulnerable. And it will include adult contacts of those immunosuppressed individuals as well. So people who are living with vulnerable people in their homes. Move to the next slide. In terms of the delivery model, this is slightly different. So we've moved on from the summer. We still have 100% population coverage through our primary care networks. So the majority of the booster programme will be delivered by local vaccination services, which includes the PCNs, the groups of practices working together, but also we have more community pharmacists joining us. So we have 11 community pharmacists providing the booster programme. We had a lot of interest. We had 126 expressions of interest, but we've only approved 11, and we've made sure that we've got that coverage that's equitable. We will only have one vaccination centre going forwards, and that will be Tunstall. So the Orowa site, their lease was up, and actually the throughput in that site was quite low. So that site won't go ahead into the booster programme. The Stafford Kingston site has been taken over by the PCNs in that area, so it will remain open. It's just the provider has changed. We'll still have a mobile team. We recognise that inequality is a big issue for us in the booster programme as well, and that mobile team will be taking the vaccine out to communities to make sure we can get high uptake rates. Hospital hubs will be in place to vaccinate staff, and we also have our school age immunisation service, and I'll talk a bit about that when we get to the children's. So we move to the next slide. This just describes some of the modelling that we've done, and we're very clear with the numbers because actually we know who have received their first and second dose. So this describes the dosing timetable, if you like, for everybody in that over 50s group. The majority in the green line will go through the LVSs, as you can see, and the peak will be around mid-October. One thing I will say is that practices and PCNs are doing this over and above their core business. So they're not delivering this with existing staff, or it will be additional clinics, mostly at evenings and weekends, because that's when the vaccine supply comes and that's when it's most convenient for patients. We move to the next slide. So we've already started the vaccination of children who are clinically vulnerable in the 12 to 15 age group. If a child in this age group is classed as clinically extremely vulnerable, and there are some details of what that might mean, they will receive 2 vaccines of Pfizer. So all children will receive a Pfizer vaccine. They won't be eligible to receive an AstraZeneca vaccine. It's Pfizer and easy circumstances. I'll move on to the next slide, if I may. In terms of the Healthy Plan, obviously, an announcement from the Chief Medical Officers last week approved vaccinating healthy 12 to 15-year-olds. The JCVI, the Joint Committee for Vaccination and Immunisations, if you remember, didn't see an individual health benefit of vaccinating individual children. However, the Chief Medical Officers have actually looked at this in a broader range in terms of the public health benefits of keeping people in school, keeping children in school, of protecting vulnerable adults, older age range that they might live with. And it's about protecting people's well-being, safeguarding and continuing their education, which I think is the primary driver for the decision by the Chief Medical Officers. We're working very closely with our partners as a system. This flow diagram here talks about how we'll be delivering the system in schools through our school age immunisation services, which is a service that's provided by MPFT, Midlands Partnership Foundation Trust. They've got a lot of experience providing vaccinations in schools. So this year we started to plan for this eventuality again in the summer. Just to make matters even more complicated for the team, this year they will also be rolling out children's flu vaccinations for all age ranges as well. So this is a new vaccination programme for senior school children this year. But actually that's made it quite easy for us to tab onto the back of their plans. So they have clinics set up in all of the schools in Staffordshire from now to mid-November, and they will be co-administrating both the flu vaccine and the Pfizer COVID vaccine on the same day. We have got a backup plan, so for children who either decline or are absent or don't have parental consent, but then change their minds, we will be going back into some schools, but largely this will be through our PCN and community pharmacy offer. And as we go through the programme, we'll make that very clear in terms of the process for accessing, call them mop-up clinics, but other alternative locations. Now, Paddy, we've made a decision at our programme board about consent, and I think this is quite an important one. Would you just describe where we've got to?
The consent model for the COVID element of the vaccination has become a little controversial. We're keen for 2 main reasons to avoid controversy locally. As Lynn said, we're going to deliver the COVID vaccine at the same time as the flu vaccine using our traditional model and team, and so they're going to be very busy. What we don't want to do is to try and start to have complex conversations around consent with children during those initial wave of visits. Equally, the Minister, when they announced this, did assure parents that there would be an opportunity for parents to be engaged in a conversation with clinicians and their children should the child express a wish to be vaccinated in the absence of parental consent, or if the parents had said no. So the Gillick principle, as they've been sort of historically called, says that a child can give consent to a medical procedure, including vaccination, if they can demonstrate that they have capacity and competency to make that decision. That's quite a difficult test, and it varies according to the circumstances, and they can be quite complex conversations. So what we're going to do locally is we're not going to offer vaccination to any child in the absence of positive parental consent at the initial visits. What we will do if children express an interest in being vaccinated, either in the absence of parental consent or if the parents have said no, is we will then offer a subsequent appointment during these mop-up clinics that Lynn's described, where we will invite the child, parent and one of our clinicians to have that conversation. So we hope that will diffuse any concern from parents that they can send their kids to school that day and they'll be vaccinated against their wishes. There was some talk of people keeping their children off school. Equally, we don't want parents going into school to try and have that conversation on the day. So we will do this as a two-step process.
Thanks, Paddy. I'll move through quite quickly now, just to give you an idea of where we are in terms of numbers and also around a care home status, because I think that's quite topical and quite important. So to date, we've vaccinated 86% have had their first dose, and 80.7% are fully dosed now, which is really positive. And we offer an evergreen model where we'll continue to go back to those people in cohort in phase 1 who haven't received their first dose, and that offer will be continually open to them, and we'll continually support people to get that first dose and second dose as well. In terms of the 16 to 17-year-olds uptake, I thought this was really positive. So we're currently at, well, 56%, let's just say that, 56% of children in the 16 to 17-year age group have been vaccinated. This is one of the highest in the region. We weren't necessarily expecting to get uptake rates at that level. We've only been offering the service for 4 weeks now, so we expect that to continue to keep creeping up as we go through the year. But quite positive to see that we've had such good uptake rates in that group, and probably tells us a bit about the children's uptake. When we've looked at evidence across the world, actually, vaccinations in Europe for children are 20%, in the US they're 40%, and in Canada they're 75%. So as you'd expect, we're aiming high. We are planning and aiming for 75% uptake, but certainly we're not going to get there very quickly. And it will be quite interesting to see next week what the parental consent looks like to get there. Just move to the next slide. In terms of care home vaccinations, we've got a very high uptake amongst residents, so 97% in Staffordshire County Council care homes and 95% fully dosed, really positive. And our GPs are continually going back into care homes to pick people up to ensure that the most vulnerable get vaccinated. Staff is really important to draw out that we've actually missed D-Day now, so all staff working in a care home need to be fully dosed by the 18th of November. So they had to have their first dose by the 15th of September in order to work within those parameters. We've got good uptake rates, and that's thanks to working with local authority colleagues and the homes themselves. 94% first dose, 86% second. The risk is we lose an important part of the workforce, and interestingly, last week it was announced there was a slight change to policy that you can, if an individual is medically exempt, they can opt out of the vaccine. So actually, I think that probably gives a get-out clause in terms of anybody who's not yet had their vaccine or doesn't intend to have it to be able to continue working. Now that slightly misses the point, so we want to make sure the absolute vast majority of staff are vaccinated. But I think the take-home message is we've got good uptake rates amongst staff, and it is unlikely to impact on the workforce going forward into the winter. And so I'll pause there, if I may, Chair, and I'm happy to take any questions.
Thank you, Lynn. Thank you, Paddy. Comprehensive area, but obviously something we've discussed through this committee any number of times. I'm looking for Angela, who wants to come in.
Thank you, Chairman, and thank you for your presentation and information. Just a question, now the flu jabs are coming on board as well, can you have your flu jab and your booster jab at the same time with no side effects?
Yes, you can. So they can be co-administered. Logistically, that's going to be very difficult to deliver because we effectively have two parallel programs and they're not coordinated in terms of delivery schedules. So GP practices ordered their flu vaccine almost a year ago. and are receiving those supplies, albeit with some delays on some of their supplies. The COVID vaccination comes through in an entirely different chain. So in some places it'll be co-administration. In others, people will get 2 appointments and they might have their flu traditionally with their GP surgery, and then they may have a COVID vaccine through one of our various clinics. The original concern around co-administration was not that there was any problem co-administering the vaccines. It was because people were nervous about the COVID vaccine being a new vaccine, and they wanted to be able to correctly attribute any side effects. And clearly, if you give 2 vaccines at the same time and somebody then has a side effect, you can't clearly attribute it to one vaccine or other. So the original separation was really just to give clarity about any potential side effects. I do remind people that when we do the child primary immunisations, we're currently giving our 8-week-old babies 8 vaccines at the same time. So co-administration is not generally a problem.
Thank you.
Janice.
Thank you, Chair. Firstly, the past couple of meetings that I've sat through and listened to the COVID-19 updates has prompted me to ask the question, have we got any other information yet on the 12 to 15-year-olds? And certainly I'd want to give my own recognition to everybody involved in the delivery programme of the fact that when the decision was made, which was very recently, we are actually now in the position whereby that programme is being undertaken. So well done, I think, from my side of things to those, and certainly the fast response from when that decision was made to the delivery, at the same time as doing the booster programme and at the same time as doing the care home as well. So my recognition to that, most definitely, I would like to make known today. But a question, if I may, on the case rates. I'm aware of the fact as well that the case rates for Staffordshire are significantly higher than the West Midlands at the moment, and also England. Are there any details that you can provide us with as to what the age range is for those case rates, and also if they've been vaccinated at all? Thank you.
Before I bring you in on that, just I would make a comment that the next item does cover some of that detail. So can we do that in summary, please, the second part of the question, because it'll be picked up as part of the next one, unless that is Claire, you want to come in on the some of the detail from a public health point of view.
Yeah, so I certainly can. I have got a slide on case rates. Sorry, Claire McIver, Interim Assistant Director from Public Health at the County Council. So I can either go over it now, or we can wait to the next item and I can do them all together, whatever's preferable. I would prefer to wait rather than ruining your presentation, but say if which I always do anyway. Sorry about that, Claire. Lynn and Paddy, if you want to just sort of pick up Janice's other points, and then we'll cover that as part of that, please.
Paddy, I mean, I don't have figures to hand, but we can find out. I mean, certainly it does appear to affect the younger age group who are unvaccinated. And if you look at the hospital admissions, that tends to be who are in hospital at the moment. Paddy, is there anything you'd want to add?
No, I think it probably comes under the case rates and the subsequent discussion on incidents. It's probably a better place to discuss it.
Are you happy waiting, Janice?
Yeah, absolutely fine. It was the first point that I wanted to make. Thank you.
And I thought well made. Thank you.
Cheers.
Thank you.
Thank you, Chair. As always on this health committee, there's always a leaning towards a personal something happened to you personally. And firstly, can I say that the inoculation rollout, his vaccine rollout is absolutely fantastic. Yesterday on Sunday morning, I was given my flu vaccine and my pneumonia vaccine, all absolutely fantastic. They had run out of I've been a very brave boy sticker, but I decided to let that one go on this occasion. But the one thing that does concern me, and this may not be relevant, Chair, so please tell me if it's not. The one thing that does concern me is there's still a level of pushback in the community, which really surprises me. I have friends and neighbours who work in the health service. Certainly they share the level of concern and the level of patients that they deal with that have not had the vaccine. And so my question simply is, you know, going forward, are we continuing to deal with that? So one of the things we did yesterday, my wife's the district councillor, we both took a minute just to have our photograph taken. We so we're really keen, and then we'll put it all over our social media pages just to sort of give it a little bit of a push, because every time a little bit helps. But is it possible to answer that question as to how we're doing for the people who are not keen on it? Thank you.
Perhaps Start and Lynn might want to come in. We're sort of fairly relentless in our efforts to continue to vaccinate anybody who's not currently had their vaccine. Lynn described it as the evergreen offer, and that's a national phrase, and we certainly use that locally. So anybody who's not been vaccinated can come to at any point to any of our sessions and be vaccinated. Interestingly, in our data, we look at our weekly variance across all of our cohorts, and every week in every cohort we see people coming forward for the first time. So last week's data, off the top of my head, I think there was 90 odd people in the cohort 60 to 65 who came for the first time to have their first vaccine, and that's pretty similar across all of the cohorts. We're seeing a steady, slow trickle of people coming through. Our comms teams are fairly relentless in picking up the messages. We try and twist and turn to answer any of the sort of themes and questions that come through. We've had recent campaigns on issues around maternity and pregnancy and fertility. We've had particularly focused comms around the care homes, which tends to be driven by similar issues around in young women around fertility and pregnancy. So we're always open for business. We're trying to answer any of the questions. We're running themed campaigns on a fairly regular basis, and we are seeing, you know, a steady, continuous trickle of patients coming through. So you know, there's an awful lot of drivers for this, some of which are out of our hands. But as people see the people around them being vaccinated, then we are seeing people come through, and I expect that to continue long into the future. Rates are, you know, in all our cohorts are steadily going up.
And I've just had a chance, Chair, just to look at some of the data. It is the younger age group where we are seeing a lower level of uptake. So over 50s, it's 90% uptake in terms of that first dose. 40 to 49 is 83%. What's interesting, where I think we've perhaps got most resistance, is the 30 to 39 age group. So our 18 to 29s are 71 and our 30 to 39s are 72. We'd expect that 30s to be higher given we've been vaccinated longer. But as Paddy says, we've got strategies in place around people coming back and the double dosing campaign, and we'll still do that targeted community vaccination as well to take the vaccine to people rather than the other way around.
Phil, do you want to come back?
Oh, I wanted to say thank you, and the words I really enjoyed hearing with our comms teams are relentless, and that's great. Thank you very much. Thank you, Chair.
Can I just add to what's been said, which is, you know, I think members will be aware of a specific councillor who was very thankful for some of the targeted work being done in his community. And I would encourage members that if you've got pockets or targets of people who aren't being picked up that you feel, please reflect that back into the local outbreak control board, because the local outbreak control board is full of representative members from districts and boroughs and from the county, and it's really important that we do pick up any concerns that individual members have got about groups, and then at least it can be discussed, and we can look at the targeting of that, and I'm sure that people on this call and in this meeting will reflect the same through the local outbreak control board. I think I saw Jill Hood.
Thank you, Chairman. I'd like to ask that we've seen the huge publicity campaign about care home workers being told that it's vaccination or no job. And I'm wondering, what are you putting in place for your own staff, your NHS staff? I personally know a number who have not been vaccinated and who have no intention of being vaccinated, which I just find incredible. So do you have some kind of programme in place to make sure that there's, you know, a bigger awareness that they have to be vaccinated?
So we monitor our uptake rates, well, for flu, and we will be doing for COVID across all of our providers in Staffordshire and Stoke, obviously working with the local authority. However, it's not mandated in terms of health and care staff. It's only mandated in the care home setting. So that does give us an issue, and obviously we can't force people, but we monitor each of our trusts. We work very carefully with staff. If staff do opt out, they have a conversation with people, with the clinician, to encourage them to take the vaccine. I mean, certainly in terms of care homes, there can be no planned visit for anybody who hasn't been vaccinated. So I think that's one lever in terms of some of the roles, but certainly it's not mandated as part of the NHS. I mean, Paddy, do you want to add to that? We've got a good uptake rate.
I think we are starting from a point where we have good uptake rates, and I think the figures, for certainly the Stafford County Council care homes are really high, and can compare very favourably to regional and national figures. So the problem we have in county is I think far less than some of the conurbations where we're seeing uptake rates in care home staff and in NHS and staff being much lower. There is a consultation that has just started on mandating vaccination for NHS staff, and so that will work its way through in the same way as it did for care home staff. As Lynn said earlier, it will depend on whether the government are prepared to how tightly they're going to enforce this. The self-declaration of medical exemption, which they announced for care home staff last week, whilst it will be well received by certainly my GPs not having to confirm people's medical exemptions, does give a little bit of a sort of get out of jail free card, if I could call it that, for staff who want to self-declare that they can't have the vaccine. In reality, there's very, very few circumstances where you medically couldn't be vaccinated. So I think part of this will come down to the government's willingness to mandate, which we'll need to see. I suspect that the consultation for NHS staff will probably go the same way as care home staff. What we can do in county is really just availability, and our hospital hubs are opening again, this week, to vaccinate the staff through UH&M. North Staffs combined are working together with UH&M to vaccinate out of a single site. MPFT and Burton will all be vaccinating their staff. They're actually really efficient, and they'll get through that very quickly. But the minority of staff who choose not to be vaccinated, that we will just need to again work away at in the same way, just trying to answer the questions, give the messages, and use that peer cohort effect to best advantage to encourage them. The question remains whether there will have to be some wholesale recommendation that patient-facing care staff will need to have their work plans reviewed, and whether from a employer occupational perspective there will have to be some sort of individual risk assessment of the risk to patients from unvaccinated staff. But again, it remains to see what the NHSE and the government will mandate.
Jill, do you want to come back?
Thank you, Chairman. It's just a statement, an observation really, that it will be very controversial, as we've seen care home staff have been told, lose your job or be vaccinated. It will be very controversial if we're saying to our frontline staff in hospitals, doctors, surgeries, etc., no, you don't have to be vaccinated, you've got a valid reason. It is going to be, I don't know, something that doesn't rest easy with me. It's a basic human right that you say yes or no, but this really is, I don't know how it's going to end, but thank you for your replies.
Maybe we'll leave that with the national politicians. So just let's summarise where I think we've got to this afternoon. First of all, Lynn, yes, we'd love to see the slides, please, if you can send them through to Debs. Second of all, I'm sure you'd want to make all members or remind all members of the vaccination webinar, which is scheduled for the 29th of September at 5 p.m. and encourage members to circulate that around all of the links that they have to try and get as many people onto that and to be up to speed. Thirdly, I'm sure that as part of that vaccination webinar, you might want to just talk about the flu rollout programme with a specific slide, because I think that's sort of one of the other elements that is in the mix here. And finally, I think it's for us to note progress that's being made on the vaccination programme. Also to thank you. This is a programme that's been running since the end of December last year. It's very easy to forget how long it's been running, but not forget the success. And actually the two are they are both linked to each other. Equally, I think we want to just thank you, picking up Janice's point, for the speed of mobilisation and the impact on Staffordshire residents. So thank you for those. Is that the view of the committee? That's fine. I think we're all in agreement. Can I suggest you just stay with us whilst we look at the COVID update, just in case there's any sort of link across the two? I would normally allow you to go, but if you could stay with us, I would be very grateful. But instead, I'd like to now hand over to Claire as part of item number 7, COVID update.
Thank you, Chair. I'll just share this presentation if you could bear with me 1 second.
We're there, thank you.
You can see? Okay, great.
Could you go full screen for us on the presentation, please?
Certainly can. That worked?
Not yet. Yeah, if you go slideshow down the bottom right corner.
Yeah, I pressed that. It's
brilliant, thank you.
Yep, are we there? Good, sorry about that. So yeah, for anybody who I don't already know, I'm Claire McIver and I'm Interim Assistant Director for Public Health and Prevention. So I work with Richard Harling in the Public Health team at the County Council. So what I'll do today is just provide a really quick update on where we're at in terms of COVID cases and our management of those cases across Staffordshire. And then I'm happy to take any questions afterwards. So as you can see here, and we've talked to this a little bit already, the table on the left breaks down the Staffordshire cases up to the 15th of September. Sorry, the extract was taken on the 15th of September. The cases actually refer to the 12th of September. And you can see a breakdown by district and borough. And then also at the bottom, you can see a West Midlands and an England average. So the blue line is the Staffordshire case rate. So you can see the trends over the past months and indeed years. And what you can see is we've largely followed the England and West Midlands rates with some minor fluctuation throughout that period. More recently, we are starting to see a bit of divergence from the England and West Midlands average. So that's something we want to have a look at in a bit more detail, and I'll come back to that in a second. But as you can see, there is some differences across the districts and boroughs of the county, but that has fluctuated up and down across the whole period that we've been dealing with the pandemic. So it sometimes reflects significant incidents, sometimes it's just a sort of an artifact of community transmission, and there's no sort of obvious reason for that. So we do keep a very close eye on those case rates across the different districts and boroughs, and indeed even smaller geographies. So you can see here that we are tracking slightly above. The most recent data, I actually had a quick look this morning, which takes us up to the 16th of September, is showing a Staffordshire rate of 381, a West Midlands rate of 296 and an England rate of 253. So actually we've started to see that gap widen slightly more. I think what's particularly useful to note though is where you can see here the grey line and the orange line on this graph. So we're looking at age bandings here. So if anyone can't see the detail, I appreciate it's a bit small. The grey line represents cases in the 11 to 17-year-olds, and the orange line or sort of brown line represents cases in the 5 to 10-year-olds. So although it's not great news that we're seeing an increase in cases being reported in Staffordshire, what is positive is that we haven't seen a significant increase in the over 60s, for example, which is where we might see more hospitalisations. And actually what we think is happening here, we've done some further analysis following our Health Protection Board this morning. We are seeing, as I say, a divergence from the West Midlands and the England average, but it seems to be that that's more an artefact of really high testing rates among that younger population in the county compared to other areas. So we've got a really, really good relationship with schools and colleges across the county, and a really positive return in terms of those regular lateral flow testing. So that is obviously picking up more cases, which is good in terms of us being able to manage those cases and sort of any direct impact on other contacts and potential ongoing transmission, but does then show in our case rate data. Here you can see the hospitalisations trend over the past months. You can see the spike here around the sort of winter period in 2020, 2021. Again, the good news is that we are not seeing in Staffordshire or across England the sort of the same trend or the same pattern in terms of hospitalisations following that sharp increase in cases. We are obviously seeing some increase, and that's just a result of the number of cases in the community, and we will see some of those unfortunately translate into hospital admissions. But as Lynn mentioned previously, what we're seeing generally is that the majority of people who are hospitalised are not those who are double vaccinated, so it's not translating into severe illness or death, which is really good news. And actually, again, referring to the point around case rates and the age bands where we're seeing that significant difference in terms of the number of cases reported, we're not tracking as significantly above the West Midlands or the England average in terms of hospitalisation. So it's not necessarily evidenced in the number of people who are becoming really, really poorly with COVID. Again, here you can see the previous sort of rates for deaths, and what we tend to look at here is excess deaths over an average of sort of 4 or 5 years, and that just gives us a really a sort of more accurate comparison, I guess, and accounts for any fluctuations and any differences in codings and things like that. So what we can hear is the yellow line is the average between 2015, sorry, the yellow chart is the average between 2015 and 2019, and then the blue is from 2020 all-cause excess deaths. So you can see the spikes where we saw a much higher rate of deaths during the peaks of the pandemic, and then you can see the most recent data we've dropped down to just slightly below average actually now for excess deaths in the county. So again, a positive story in terms of the direct impact of those cases. And here I won't dwell on this in any detail because you've already had an update from Paddy and Lynn, but just a really positive story in terms of uptake and coverage across all ages, actually, even in that younger age group. Obviously some plans in place to start the 12 to 15-year-old vaccination programme very shortly, and we're sort of working with NHS colleagues wherever we can to support that programme in terms of using community champions, any of the insight that we have through our outbreak management work, access to workplaces where we know we've got high levels of poor uptake, and those kind of things, and sort of campaigns that are targeted specifically around any of those cohorts where we need to focus efforts in terms of increasing uptake. So we've got a new young persons campaign, for example, that will be launched shortly. And that's it for me today. Thank you, Chair.
Claire, really useful. Thank you for that. And for members who were struggling with the screen this side, you should now have that in your inbox, the presentation. So please feel free just to access that whilst we talk. Just let me make one other point, which is if members haven't been to their own district or borough local outbreak control board, I would encourage you, if you don't already sit on it and you haven't been to it, to go to a meeting. They're every 3 weeks or so, roughly, and it's a good demonstration in terms of seeing how the process works on the ground. When Claire talks about, there is a local investigation of every case, I think that 93% of contacts are traced these days from within the county council area, and equally the hotspots are identified to try and track back. So if you haven't been, please identify who your lead is on that and make sure you go and visit one of the local outbreak control board meetings in your district or borough. I think you would encourage that, Claire, wouldn't you?
Absolutely, yeah. I think, like you say, it's a good way to not only understand how we respond and sort of interrogate that information at a very local level, really getting down to some of that granular detail, but it's also useful for us to hear from anybody who's on the ground, whether that be professionals, people with local insight, councillors, just to understand what things are likely to work in the community, what barriers there are, as well as any intelligence around specific incidents that are ongoing. So yeah, absolutely, any input welcomed.
Thank you for that, Claire. I'm going to bring Janice in just to see if we've answered the question she had earlier, and that look of surprise was always good.
Thank you. Just to try and get some more clarity on the case rates, I heard what you said about sometimes we can be too good at something, so if we're testing a lot more here than what other places are, then it will skew the figures. Just in terms of the case rates and if they've been vaccinated at all. So again, I appreciate the 11 to 17s are less likely to have been vaccinated, but that wasn't all of that demographic that was on that particular slide. Does that make sense?
Yeah. It does, yeah. So unfortunately, we don't have, so when we get testing data through, we don't have that person's vaccination status as well. So those two data sets don't quite talk to each other in that level of sort of detail. So what we can look at is overall coverage in the specific age groups, for example. So as you say, we've got a really good level of uptake and coverage in the 16 and 17-year-olds already, which is really positive. And although there are some sort of anecdotal examples of, of parents being concerned and asking questions about the 12 to 15-year-old vaccination, we've got no reason to believe uptake will be, worse here than anywhere else. And actually, because we've got such a good school immunisations programme in Staffordshire, and uptake of other school immunisations is now back up to where it was pre-COVID, we've no reason to believe that that will be any different. In terms of any other examples we've got of vaccination coverage compared to case rates or the ongoing sort of impact of COVID, what we tend to look at is things like hospitalisation. So as Lynn referenced previously, we're not seeing a significant number of people who are hospitalised or indeed significant deaths from people who have had 2 vaccinations, although it will happen. None of it's 100% sort of foolproof or even 100% effective, but we are seeing the impact of those high vaccination rates because we aren't then seeing that translate into increased hospital admissions.
Can I just ask whether Lynn or Paddy wanted to come in on anything that Claire said? I'll take that as
Sorry, I'm a bit slow. No, I don't think I've got anything more to add than that. I mean, the UK has been trying to flow all of the data related to vaccination into a sort of central repository. It is one of the sort of successes of the programme. But we don't always get the level of detail that we require about sort of at an individual level. So we tend to get a sort of much broader picture.
Thank you. Janice, do you want to come back?
I think it's a point well known that the one will lead to the other in terms of if you can evidence the effectiveness of it, then it may encourage more people who are less willing to want to take it up to do so. The natural sort of lead on from that is to look at the hospitalisation and the death figures as well, and to see how many of those we appreciate that anecdotally from my perspective that if you've had both vaccines then you can still get it but less likely to die, but again I think it's how we can use that information in a positive way to try and encourage others who may be hesitant. Thank you.
Marcus, I'm hoping you're going to make the point about excess deaths and dying with COVID rather than of COVID.
Yes, I could certainly make that point, Chair. Deaths are recorded within 28 days of a positive test, so I think that's a really important point in that someone could die with COVID, but not necessarily of COVID. So my mother-in-law died last year. She had COVID on her death certificate, but she actually died of pneumonia and she had dementia. So there is there is an issue around, I guess, how deaths are recorded. I just wanted also just to pick up Claire's point around, yes, we do have relatively high case rates, and I think the UK's got the highest case rates in Europe. But because of the vaccination programme, because of the immunity through recovery from a prior infection, most of the cases we're seeing are asymptomatic or resulting in mild illness. So as Claire said, all of our hospitals at the moment are fairly stable. So UH&M at the moment has got around about 80 people in a bed with COVID. That's been the case for weeks and weeks and weeks, and I do look at this data every day. In January, it peaked at around about 360 people with COVID in a bed. UHDB, Derby and Burton, 55 people with COVID in a bed. That's been pretty stable as well, and they had about 480 in January. Our biggest hospital, the biggest hospital by beds in England is University Hospitals of Birmingham. They've got 199 in a bed with COVID. They were about 1,000 in January. The level of people in hospital with COVID is way down on what we were seeing before. And in terms of the death rates, yes, death rates are in the sort of about 100, 150-ish, which again is far lower than you would see. It's probably a third to a quarter of what you would see in a bad flu season. So just looking at case rates is what we tend to do, only gives you part of the picture. And I think Claire's absolutely right. If we're testing more people, you'll obviously get more positive tests. When the pandemic started in sort of March, April of last year, we're only testing about 5% of people, picking up 5% of the cases. We're not picking up 100% of the cases at the moment. Some areas are doing more testing than others. So I would probably suggest that the rates are probably going to be similar-ish across most of the country. The reason we're testing higher may well be, as Claire said, because we are actually testing more people. The people who are testing positive tend to be younger than they were sort of a year ago. And most of those, as we know, will be asymptomatic or will have a very mild illness. So just, I guess, a sense of perspective on this, in that we need to look at all the data, not just the case rate data, as Claire said before. None of that means that we're not going to have a really, really difficult winter, because we have an awful lot of people who were, lockdown works as well for any infectious disease or respiratory condition as it does for COVID. So, lots more RSV at the moment, human respiratory syncytial virus, which particularly impacts on children. We would normally see around about 30,000 children being hospitalised with that in the winter, and we're seeing that earlier now. So in August we were seeing what we would normally see in the depths of winter, and again lots of people who haven't picked up colds and all the other bugs that you would normally get around about winter time. We're seeing a lot more of that now at the moment. So lots of people with bugs which aren't COVID, but which can also be pretty unpleasant. I mean, you might need a few days in bed. And obviously the flu season, we didn't have a flu season last year, and we don't quite know what to expect. So that's going to hit us pretty hard this year. So COVID, very different situation to where we were in January. But it's not all about COVID this winter. There's a whole raft of other challenges that the NHS and social care will be picking up, which is going to make for a pretty difficult time. Thank you, Chair.
Thank you, Marcus. Janice? Philip Atkins.
Thanks, Chairman. Marcus has answered some of what I was going to talk about. Slide 5, which is deaths, is a little bit obscure. You've got to have the proper information before you can make a decision, and whereas the blue line of excess deaths is above the yellow 5-year average, we can't see how far below the 5-year average it's dipped, nor can we see what the causes are below the dip. Because, as Marcus has just said, there's been people who haven't been treated. There were people, and it is very morbid, I have to say, that people who died, who were going to die. So that will mean that the deaths will be reduced. But there are also coming through now people who should have had treatment, who will be dying because they've missed treatment. So although as the graph that we saw peters out over the last few months, and obviously the deaths are below the 5-year average, we don't know how much below, we don't know the causes of those deaths. You can go on the ONS site and see that there are far more deaths from flu and pneumonia than there are from COVID in June and July. So there's sort of I hate to have to use the word scare tactic of lockdown on COVID. Actually, the deaths are because of other reasons. And that is because people haven't been to get treatment for a variety of reasons. And I don't want to start off a conversation about GP access and access to consultants and proper treatment. But certainly people, if they are worried, they should immediately get there. There's plenty of stories in the press. But my query is, the blue line, how far below the yellow line does it go? And are we seeing more deaths below that line from other aspects? This with COVID in the last 28 days instead of COVID is very much a distraction.
Claire, it was your slide. Are you picking that one up?
Yeah, I can do, certainly. So we do collate the information about, so as you say, there's different types of information around COVID deaths. There's the information around COVID recorded within 28 days of a death, which has got its benefits, but also is sort of flawed in many ways. which is why we do use the excess deaths data to give us an overall idea of the number of deaths we're seeing for the population as a whole, and which is also why we look at a 5-year average, because there's always fluctuation in any year and in any sort of shorter period. I've just had a quick look on the dashboard that we use to record deaths across Staffordshire on our COVID dashboard, and the difference, so as you say, you can't see where it's just dipped below the yellow sort of banding. The difference that's being reported in this week from the 5-year average is 13 fewer deaths, so it has only just dipped below, but we do capture that information and do look at that routinely. I don't have a breakdown of causes of all of the deaths. I've obviously sort of prepared the COVID information specifically today, but as you say, it's a very complex and nuanced sort of bit of analysis, and interpretation I think is particularly useful. So we do look at all of these things in the round, so not just the sort of cold information on case rates or standalone information on deaths or standalone information on hospitalizations. It's all of those things combined that we tend to look at, as well as testing rates and positivity rates and things like that. So the amount of people that are coming forward for tests and the proportion of those who are then coming back with a positive result. So 2 or 3 times a week we look at that data in the Health Protection Board, and as is mentioned previously, through the local outbreak control boards as well, in a lot of detail. So absolutely accept that none of this information is completely sort of flawless, but that we have it to guide us in terms of trends and give us a sort of an idea of where we need to focus our efforts and where we need to sort of think about things that we need to be doing differently, I guess, and where we might be doing quite well.
Thank you, Philip. Did you want to come back? And I would just make one other point, which is there is still the national government review of what's gone down nationally to come some stage later. Philip, do you want to come back? No? Okay, Thomas J.
Thank you very much. We often hear about vaccine take-up rates and the things that have been done to increase that, particularly in the younger cohorts. Do you think that's necessarily the right metric to look at, though, given that infection rates in the younger cohorts have been much higher recently, so arguably they've got more natural immunity than the older cohorts? Do you think it's necessarily the right area to focus on driving up that take-up rate and spending effort there when they've got natural immunity?
Claire, one for you.
Go on, sorry. Are you going, Paddy?
Yeah, I think the standard line is we don't know whether a natural COVID infection will create the same long-term immune response that vaccination will. So we're not working on a policy that those who've been infected don't need to be vaccinated. So we will vaccinate anybody from 28 days after their infection. We'll choose to vaccinate them. And that's sort of just the sort of data gap really around how much response you get from a natural infection, and in young people, they're often very mild infections and or even subclinical infections where people don't even know they've had them. So it's very tricky to then extrapolate that and say that you've got the same level of protection as somebody who's vaccinated. So I think we will be continuing to offer vaccination across all of the age ranges. Clearly on the ground in terms of whether that gives additional benefit over and above the vaccination program, it clearly may do, but it's just very difficult to quantify, and nationally we've not been relying on that.
Do you want to come back?
I suppose just do you agree that it's less of a concern if the younger cohorts, if they're 50, 60, 70% compared to the older age groups where we're trying to get above 90?
I mean, again, the argument has been very different. When we had the first patients through in over 80, and we were saying that for every 150 immunizations we gave, potentially one life was saved. Clearly, when you get down into the younger age groups, we're not talking about saving people's lives. It starts to become a much broader argument around the whole community protection, transmission, disruption in schools and in employment and other circumstances. And And now, to be honest, the biggest driver for a lot of our young people is foreign travel. You're not going to get a vaccine passport unless you've been vaccinated. So I think the argument shifts from the personal protection in the elderly and vulnerable to a much more wider societal benefits for vaccination in the younger age groups. But for a lot of other national vaccination programs, we are aiming to get 85% uptake rates plus in order to reduce transmission and protect those people who will either not be vaccinated or whose vaccination will inevitably not be as effective because they're immunosuppressed or have background underlying medical conditions. So I think the argument shifts across the age bands, but the broadest argument is we need everybody to be vaccinated to protect those people whose vaccination may not be effective.
Anything further?
No, thanks for the answers.
So just before I bring this item to a close, just encourage any member who hasn't asked the questions they want or are engaged so far just to formulate it. Otherwise, I'll just bring members' attention to the Zoe COVID study and the app that goes alongside of that. And the more people who engage on that gives very early health indications as to the effectiveness of things like the vaccination and side effects and things like that. There's also a wealth of information there, so I would encourage members just to circulate that round. Is there any further questions? No, on that basis, let me do a couple of things. First of all, Lynn, Marcus, Paddy, thank you for staying with us. I appreciate that. I think it's a really good, useful demonstration of partnership working, that it isn't just one strand of people or one set of people who are trying to fight against the pandemic. So you talk about partnership working, what better way of demonstrating that than in action? So thank you for that. Claire, thank you for your slides earlier today, really helpful, very clear and concise, thank you. Please can you also take the thanks of the committee, I'll just check that they're happy with that in a minute, to all of the people within your teams, public health and social care, who are involved in the fight against COVID. We often talk about the NHS, we obviously mean that as shorthand for NHS, public health and social care, so please can you take that back as well? Are we happy with that? Good. Okay. So on that basis, I'll bring that item to a close. Thank you. You're welcome to stay or you're welcome to go, whatever you feel. Let's move on to the district and borough health scrutiny activity. Now, not wanting to prolong our meeting this morning, we don't often spend much time on these because we're all, the agenda expands the amount of time available. So I would encourage the opportunity just to talk a bit more about what we're doing locally, because frankly, the local impact is really important. It's, here we talk about what affects across the county. It's actually what's also driven through the local committees that are really important. So on that basis, let me take the agenda item 8. And shall I start with Cannock Chase? Mr. Hewitt.
Thank you, Chair. I don't represent Cannock Chase on this committee, as I often say. Unfortunately, we have had a slight problem in the sense that Martin was at work, Councillor Buttery was at work, who would normally be here. He had a representation from Councillor Thompson, who's got a family member who's ill, so she's cancelled. What I will do, I will make sure that I drop an email to Martin to make sure you get a full written reply, a full written report from the previous meeting. I think you would have got a verbal one this morning. All right.
Take your point exactly. You and I have had that conversation before. I thought you might have touched on the MIU at Cannock, because I understand from the first presentation this morning that it was closed still. And I know that you've been very active in trying to get that MIU reopened.
We are being fairly relentless about getting the MIU opened, and we're not stopping. And that's very much part of the conversation. That's why I wanted a written report. Unfortunately, with two of them being away on unforeseen circumstances, so it's just an apology from Cannock Chase. But you will get that written report.
Appreciate that, and all the work that you're doing on the MIU and getting it reopened.
We're not going to stop, Chair. Thank you.
Then we move on to paragraph 8, which is e-staffs.
Thank you, Chairman. I couldn't get to the 2nd of August meeting, but I sent a written report of our meeting, particularly Wallis Quarry, and they've got a meeting on Wednesday. So I've found actually sending a written report and abbreviating the minutes of this meeting and just making it into a brief description of what we've been doing here is quite useful, and I thought they circulated it at the meeting and they found that very useful from what I heard from the officers. So the meeting's on Wednesday.
Appreciate that. Philip, thank you. Lichfield meeting was on Thursday the 16th of September. I think that's been put on the spot, is it?
Yeah, thank you, Chairman. We have changed from 4 overview and scrutiny committees to 1, and I chair it. I've got a list of things as long as your arm to scrutinise, and I'm afraid at the moment health isn't coming into it, other than at Thursday's meeting, we had some discussion on our climate emergency declaration. But other than that, we've not broached any health matters, although, as you're well aware, we do have enormous problems with in Lichfield District with access to GPs, but that is a county issue and we can't deal with it locally. But if it could be dealt with at county level, it's impossible to see a doctor in Lichfield at the moment. It's as simple as that.
Thank you. Just in terms of a couple of comments, if I may, the climate emergency is being picked up within the County Council through the corporate review, and thank you. And equally, Prosperous is picking that up. In fairness, I probably welcome that as an approach because it is cross-cutting and the breadth of remit within health is quite significant. So I'm more than happy that other committees pick up that. So that's where it's being picked up. So I wouldn't want you to think that it's lost on us. We do have a role within health to make sure that our partners within the NHS and within social care also have robust climate change plans, and you will see that come back here at some stage. But that's probably the sum total of where we'll look at climate change because it's been picked up within Prosperous and within corporate. The other point I was going to make was on GP access, and I'm assuming that one of the points you're recommending for the next item agenda, the work programme, is that we bring back a discussion on GP access. Is that what you were suggesting?
Yes, please. It's of fundamental importance that we should be able to see a doctor. And I speak for myself, and without boring you, I hurt my foot in April. I'm still hurting because I can't see a doctor. I can get to see anybody if I'm lucky. I've had 1 appointment with a physiotherapist. I've seen a couple of nurses, but I still don't know what's wrong with my foot. So if you wonder why I'm wearing some very odd shoes, they cost me £100 and they're the only ones I can wear.
I'm sure they were picked up on the live online broadcast, and they look very natty. But I take your point. We'll come back. Maybe you can raise in the next session about GP access. I've now lost my page. Okay, we can't really talk about Newcastle because Councillor Wilkes has sent his apologies this morning. Instead, let's move on to South Staffs. Joyce.
Sorry, first time. We haven't had a meeting since we last met here. We should have had one last week, but we deferred it to October the 5th because we lost our leader, Brian Edwards, and we are meeting on the 5th of October where we actually will be discussing children's mental health and well-being. I think we're deferring the breast screening service because I understand the presentation for the children's well-being mental illness is quite lengthy and we want to give it adequate time So we're deferring the breast screening till the following month. Thank you.
Thank you for that update. And yes, I was very sorry to hear about the passing of Brian Edwards, who was a long-standing servant to South Staffs. Stafford Borough 13. Is there anything you want to add, Chair of Stafford Borough? I believe you've got a meeting very shortly.
I have very little to add, Chairman. I will say that our meetings are varied, and I think quite often it comes back to mental health, lack of resources, which I know are very concerning to the committee. In particular, Councillor Edgeler raises the mental health issues quite often. We're struggling in our division with access to doctors, but that seems pretty much throughout the county the same thing. So that's really all I've got to say, Chairman. Thank you.
Thank you, appreciate that. Maybe we can talk a bit about mental health in a minute as part of the next item, not wanting to brush over the importance of it at all. So that takes me on to paragraph 13, which is Staffordshire Moorlands. Barbara.
Thank you, Chair. We held our meeting on September 15th, last Wednesday. We had 3 presentations. The first one was the aftercare following discharge from hospital, where he said that they try and get 33% home by lunchtime, discharged by lunchtime. It had gone down to 24% due to staff shortages. The second presentation was the Midlands Partnership Foundation Trust annual report. They were talking about the hubs. It was as well that they want to have consultation with us what the hubs. It was also brought up about the minor injuries unit, that they were turning people away and only appointments. And then the third item, which was the longest item, was the West Midland Ambulance Service. And I've got quite a report, but I will make sure you get a written report from the officers. And he raised the general points. Given the past year, the workforce were tired, staff morale was very low, staff were regularly late for off duty, which had a knock-on effect the following day. The Trust has moved to REAP 4, the highest level of concern for the first time in its history. The service were well prepared to deal with the pandemic, as there were no vacancies, had all of the necessary PPE, a fleet of new vehicles, and 86% of the staff are now fully vaccinated. The Trust had a vision for many years to introduce large hubs, as this gave the opportunity to work more effectively and efficiently. Paramedics rarely returned to the stations unless they had an opportunity for a meal break. The money saved from not having the community ambulance stations could be invested in additional staff and ambulances. The officer gave real-time data to the panel. A major issue was the number of lost hours due to delays handing over patients at hospitals. West Midlands Ambulance Service was looking to develop a community response model and had recently introduced a clinical valuations desk. A copy of the statement read out from the leader stating the closure of CAS would put lives at risk, and residents of the Moorlands will not receive the service they deserve, would be brought to the attention of the Trust Board. Members were concerned about a reduced level of service currently seen by patients in the area, and were worried that the removal of the CAS would lead to further reductions. It was thought that ambulances would be deployed to urban areas before attending the rural areas. The officer agreed waiting times were acceptable. The demand for ambulances had increased significantly, and this was an issue for the whole of the region. The Trust did not have the resources to cope with the demand, and members felt that these issues needed to be brought to the attention of the government. And I'd like to propose that the West Midlands Ambulance Service are invited to this committee, because it's it's not just the Moorlands, it's the whole of Staffordshire. And I don't know whether you're in agreement with.
Thank you, Barbara. So just let me try and pick up a couple of things if I can, please. So in terms of the community ambulance hubs, where there's a consultation going on at the moment about the reduction of 2 in the moorlands, that is an issue I think that you picked up and you're leading on because it only affects Staffordshire moorlands. But I think what your proposal is that just like GP access, we should take on a scrutiny session on West Midlands Ambulance Service performance.
Definitely, yes.
Does anyone else?
Utoxeter has also been closed.
Sorry?
Utoxeter has also been closed. Utoxeter has already been closed. It's not just Staffordshire Moorlands.
I only saw, I wasn't aware that the community ambulance service station in Utoxeter was part of those consultations.
Well, what I'm saying is that there are stations all over the place, and there is a consultation relating to the ones in the moorlands, but there are stations all over the place, and the plan is to close them all. Now, I have to say, although Barbara, gave a good report, that I think I've probably never heard such a devastating report from the ambulance service. I really have never heard such a drastic and appalling, desperate report from the ambulance service. I mean, he was absolutely broken. Just going back on those points, the last point first, I would tend to agree with you. I watched the event live, and thank you to the Moorlands for broadcasting that in that way, because it allowed me to engage and just see that, so that was helpful, thank you. And one of the reasons I think we should invite the West Midlands Ambulance Service in front of us is to have a better understanding of what that is on the ground. We've heard from Marcus Warnes this morning that he's concerned about the delayed handover of patients. It's not unusual to hear of 6 hours, and I think that we can't, whilst we could leave this to government, and I'm not saying this isn't a national issue, I think we need to make sure for the benefit of our residents that we do bring this in front of us rather urgently to have a better understanding of what that is, because the whole system isn't interacting together, and it feels very disjointed at the moment. Maybe that's because every part of the system is under pressure, but I prefer to bring someone like Anthony Marsh and Mark Doherty in front of us as a committee. Does everyone support that? Going on to the issue of ambulance hubs, I'll have to go and look at that one again, because the information I've seen on ambulance hubs was it only affected within Staffordshire, the Moorlands, and you'll be aware I'm not keen on scrutinising issues that other people are looking at, because otherwise what we do is we duplicate resource and we'll end up with a lack of clarity as to who owns which problem and which issue and the solution. I'll come back to you on that if I can, please. Barbara, was there anything else you wanted to add from Moorlands meeting? And are you happy with the proposal to bring the ambulance service? Right. Okay, we'll move in very quickly on to work programme. We haven't touched Tamworth, so let's go on to Tamworth.
Councillor Claymore had to leave about 12:30, so I'll pick it up. So there hasn't been a meeting of the committee since 13th of July. There is one this Thursday, and we'll bring the details of that to the next meeting here. Nice and simple.
Thank you. And I also note, and I trust you won't lose those items from the last meeting that were raised, in terms of healthy eating from memory, which we'd like to incorporate into the wider determinants of health discussion that Councillor Edgeler is working on for early next year. So, can I move on to the final item on the agenda, the work programme, item 9. So, whilst the minutes suggest for the work programme in October, that we're looking at Monday the 11th of October for a workshop on mental health. And this is a workshop rather than a public forum. We will record it for those people who aren't available to join us. But the idea is to try and give a wider view on the various strands of mental health. You know, so I think it's very easy for us to talk about mental health, and yet, you know, is it community mental health or is it acute mental health? And I think, you know, a better understanding for both new members and us old lags is probably a good thing to do. The date of that is the 21st of October at 2 p.m. One of the reasons it's important is not just from a sort of an awareness point of view, but it's also important because the county early next year will be bringing forward their mental health plan and strategy, and we'll be looking for early input and consultation within that. And I think obviously if we all start from the same point, that's a good place to be. So the meeting for the 11th is actually should read Monday the 21st at 2 p.m. And Angela.
Thank you, Chair. I mean, we're talking about mental health, and I just want to make you aware there's a public consult. You know, we've got the mental health strategy, which hopefully is going to come out in April next year. But following up before that, there's a public consultation going out at the end of September. And I want you to make you all aware that please contact all your different groups that you've got in your area to make sure that they give their input into the mental health consultation, because whether it's good or bad, we want to know about it. So, sorry.
Thank you. And just a point of clarification, it's Thursday the 21st.
In terms of the consultation, can I just ask if you can send it out to all members, not just the Health Committee members?
It will probably be told at the County Council meeting as well, so yes. Right.
If you can send out that, the information, so then it can go around all the parish town councils and all the groups, that would be great. Thank you, Anne.
Thank you.
And I think the point is also maybe a very specific call to action for county councillors to ensure that they pass it on to all district and borough councillors, plus any parish councillors that they engage with. I think that's the wider point you're making, isn't it?
Yeah, I think the thing is, we've talked this morning about pathways, and this is what we're looking for mental health, for a pathway, you know, so people will know where to go. It's so fragmented, so this is what we want to get it all together for the mental health strategy.
Thank you. So let's just move on to the meeting of the 25th of October. The current proposed agenda is to pick up something on COVID if we need to, accepting we might not need to, but I think we'll leave that for closer to the time. Secondly, to pick up an update on Wally's Quarry. Members will be aware that there was a High Court ruling last Friday on Wally's Quarry. If not, maybe worth pulling that down, and in favour of the plaintiff. So we've agreed to bring that back, accepting it's a bit of a movable feast, but you know, the real question is, has the Environment Agency moved sufficiently far in the timescales that they outlined to reduce the health impacts on those members of the public? So I would suggest that, you know, for the moment we do look to keep that in the diary for the 25th. I'll take you a minute, please. The next point is we've been working on a set of KPIs and a dashboard. This is very amorphous, and unless it is diarised to come to a meeting, we'll still be working on it in the next 12 months. It's 12 months worth of work so far, and I'm still not got to anything which looks like a dashboard. So I think I would like to recommend that we kept that as a dashboard. And that's because it's very easy for clinicians to come in front of this committee and talk and use big long words, and actually having some data is quite helpful. I'm not saying it's going to be the right data, but it has been a long-standing aspiration that we do have a dashboard that we can have and we can scrutinise once maybe every 6 months, just to see the long-term trends, and so that some of the issues that were brought forward today about the ambulance service aren't news to us. They are things that we can track and see and say where we're uncomfortable or concerned. Are members in favour of the KPI as a principle? Fine. So I would suggest we try and keep that in the diary because it is important. Whilst it's not urgent, it is important, and it's very easy for it to slip by. There is a review of independent inpatients in terms of mental health hospitals, and I think that is time-bound. So that is something that needs to be there, and the transformation of programme, how community diagnostics policies fit with the service is designed to try and give you an overview. Now, I guess my point here is if we're going to try and slip in 2 extra meaty agenda items, which is West Midlands Ambulance Service and GP access, I'm not convinced we can do that in October. So would members like to bump the October agenda or put a meeting into between October and November? Or are members of the view that we could wait till early December to look at those 2 issues? Anne, you wanted to come in.
Thank you, Chairman. I just wanted to question the meeting that we had at Newcastle regarding Wallace Quarry. Do you think our intervention had any help moving forward with it? I just wanted your comments on that, Chairman.
I can't really comment on the actions other people take. It's very difficult for me to do that. What I would comment, however, is I have within my inbox a response which I haven't been through in detail from one of the ministers, and I need to just do some work on that to know whether it's had any impact. We will obviously share that with partners, and I would assume that committee would be keen that if it hasn't had any impact, that we rewrite to the government again to express our frustration.
Thank you for that.
Phil.
Chair, I'd prefer to push back to November for your question that you asked before. For no other reason than I have a fairly full diary, and I'd be concerned that I'd miss that, whereas these are fairly solid in my diary, these meetings are. That's just a personal point of view, that you know, these meetings are reasonably solid. So, yeah, I'd prefer to push back.
Sorry, just to be clear, push back the agenda or put a new meeting in the diary in November?
Oh, no, not put a new meeting in the diary, push back the agenda.
Right.
Obviously, some people can disagree with me, as they often do, Chair.
Sorry, that's not very professional of me. I do apologise. Thank you for your input, Phil. It's as helpful as ever. I appreciate that. Okay, so what do other members think and feel? So is that the view unanimously of committee? Barbara?
Can I just mention, it may take a while to get the ambulance service. It took us months and months to get them to come to a meeting. That's why we did it in a way through Teams, because he couldn't really make an excuse for not coming. That sounds awful, but that's right. But I'm just saying it may take you a long time. Yeah.
Okay, so does anyone want to add to the work programme in any respect? On that basis, I will take that as a no. Sorry, did you still want to come in?
I just want to ask a question. Where do we sit with such as, I mean, we're talking about the hospitals and that, with the eye clinic, and because I'd like to know how we're moving. But I mean, I remember the chief exec from UHNM, I've forgotten her name now, the chief exec from the Tracy Bullock, coming to a meeting, and this must be 2 years ago now, talking about the eye clinic and services at the eye clinic. And I asked the question about the county hospital and the eye clinic there. And she said, oh yes, it's definitely coming back, it's coming back. But I'm finding that everybody in Stafford area is now still attending New Cross and the eye clinics there. So I just wonder where we sit with that.
So I should just declare an interest. I have been to New Cross for the eye clinic, but I wonder whether, in terms of the list of things that we're working on, whether we should just put it on the list, or whether this could be handled through an exchange of correspondence. But if you're happy with either of those options, then I would suggest
Chairman, I'm quite happy to take that on board with you, Tracy Blunt, myself, and come back with an answer.
Okay, good. I think that's a productive and positive end to where we started. So thank you members for your involvement, interjections, and positive challenge of those in front of us. Safe journeys. Enjoy the rest of your day. Thank you.